Good morning. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. Thank you for joining us this morning for a very important session today entitled Choosing Wisely, Opportunities and Challenges in Curbing Medical Overuse. We are grateful to the Robert Wood Johnson Foundation for their support of the event and, of course, much of the work on the Choosing Wisely initiative that you'll be hearing about today. It's very exciting for us to host this forum. It is a blend of the things that we care about most at Health Affairs. First of all, as you will hear, Choosing Wisely is an important and interesting, innovative initiative. A lot of creativity and thought went into how to do this. It's not your garden variety healthcare, and we always like being part of the discussion of those areas that are the cutting edge of healthcare delivery. It's also plays to our role as an empirical journal. We released two web-first publications, peer-reviewed articles on the topic in conjunction with this event, a couple of blog posts, and we've had a number of publications on the topic, a number of journal articles on the topic in the past. Many good ideas are good ideas, and then when put to the test of empiricism, they don't always pan out. And what we aim to do at Health Affairs is to help move beyond just the good ideas to an understanding of what works, what doesn't, and that gets to the other part that makes this exciting, which is to tackle the challenges of implementation, that even the best of ideas rolled out in the best possible way improve as they are implemented, as people grapple with the concepts, with the culture in which innovation attempts to take place, and learn from each other as different actors strive to make change. And so at Health Affairs, for us to be able to highlight an important initiative, to bring empirical evidence to the initiative, and to help move forward with actual implementation and improvement is very much the kind of thing we like to do. And that's why we're pleased to be able to bring you together this morning. Just to give you a sense of what we're going to cover today, we're going to begin with a more conversational approach with some of the leading thinkers around Choosing Wisely, how it came into being and where it stands, what makes it unique. We'll then move to a panel talking about what's been accomplished through the initiative, and after a break, we'll talk about where we're going, what are the remaining challenges and opportunities for moving forward. We'll close with some reflections on what we've learned today and some announcements about some future efforts related to Choosing Wisely. And so as we begin, we're going to have, as I say, a bit more of a discussion style with Rich Barron, President and Chief Executive Officer of the American Board of Internal Medicine and the ABIM Foundation. Rich is certified in internal medicine and geriatric medicine and was in that practice for almost 30 years. We're going to hear from Sue Mende, Senior Program Officer at the Robert Wood Johnson Foundation, who's been very involved in the initiative, and she is a public health professional with more than 25 years of experience working with underserved populations in the US, Asia, and Australia. And we'll hear from Jessica Rich, Vice President for Policy and Mobilization at Consumers Union, also very much involved in the Choosing Wisely campaign. She spent more than 25 years at the Federal Trade Commission in the Bureau of Consumer Protection. So I'm going to sit down to encourage the conversational style, where this is a very important part of the program. And now, with my conversational voice, I'm going to ask Rich to talk about the genesis of Choosing Wisely and a little bit about the structure that makes it unique.
Thanks, Alan, and thanks to Health Affairs for coordinating this event and publishing a number of really important studies about Choosing Wisely. Choosing Wisely represents a practical expression of the core mission of the ABIM Foundation. The mission of the foundation is to improve healthcare by strengthening medical professionalism. And it sounds kind of airy-fairy, like how can you do anything with medical professionalism? That's just a bunch of people saying stuff. And How do you get from the aspiration to do the right thing to actually changing behavior, to actually frontline conversations, frontline actions? And that's what Choosing Wisely is all about. Before I go any further, I need to give shout-out thanks to our partners at the Robert Wood Johnson Foundation. You'll be hearing from Susan, but definitely RWJ's investment has leveraged the campaign. And my colleague Jessica, Consumer Reports Consumer Union, the partnership of a consumer organization and professional organizations to find better ways to get the message out has been key to the campaign. But fundamentally, what's this all about? How did this come to be? The idea of the campaign was to figure out a way to support difficult conversations that people might be interested in having, they might not be interested in having them, but to try to find a way that we could engage clinicians in talking with patients about the potential of overuse and risk and harm from unnecessary procedures. Let's do a time flashback. There are things in healthcare policy history we'd rather not remember, but death panels, the big conversation about death panels. Once that was out there were a whole bunch of conversations you just couldn't have. If you started down that road as a clinician, patients were terrified, clinicians felt like they were in space they shouldn't be in. Everybody was running away from those kinds of difficult conversations. And it really was a whole category of things of which we must not speak. And there was a national policy conversation, in effect, saying to people, if they're talking about this, you should run the other way. And we really needed, frontline clinicians were flummoxed. How do you even get into that space? How do you take this on? And meanwhile, at the policy level, we're starting to have a national conversation about how do we get on top of cost? How do we improve quality? How do we reduce waste in a healthcare system? And so what was the design behind Choosing Wisely? It was basically structured to have minimal control on the part of the foundation organizing it and maximal engagement on the part of all of you who participated in it and who took it on. How did that work? The concept was we're going to produce a list of 5 things that are probably being done more than they should be and maybe should be questioned. And this was pioneered in early work with the National Physicians Association looking at primary care stuff. And it was basically the guideline process turned on its head. Instead of trying to identify all the things you had to do, what are some things that maybe you shouldn't be doing? And there were only 4 rules. It needed to be in your discipline. You couldn't be talking about what somebody else ought to do. It needed to be of impact, either because it was very expensive or because it was done very often. There needed to be evidence for the idea that it was being done too much or shouldn't be done, and you needed to have a transparent process. Those 4 rules. That's it. That's all it was. Let's think about overuse, inappropriate use, risk and harm. Let's create an architecture with 4 potential areas, and let's invite people in. And here we are 5 years later. First there were 13, then there were 24, then today there are 80 societies that have stepped up in that process and lent their intellectual capital to thinking about this. And how do we judge success? Well, today that's a lot of what we're going to be talking about, and you'll make your own conclusion. But from the foundation's point of view, I go back to the idea that this was about supporting people in having difficult conversations, that you're all here, that 80 societies stepped up, that clinicians around the country, health systems around the country are finding ways to use this as a structure to have these conversations. That's what we were trying to achieve when we started, and we're really pleased with where we are, and we're grateful for all of the engagement that you, health affairs researchers, and others have today. So thanks for being with us today, and look forward to learning with you more information about what's going on. Turn it over to Susan.
Thank you. Is this on?
It is.
Oh. That should be the start of a joke, but I can't think of a joke because I haven't had enough coffee. But see me at coffee break, and I'll try to do better. So thank you, Alan, and thank you to Health Affairs and to and to Rich and to Jessica. I'm really happy to be here with you this morning because we're going to be hearing some of the really fantastic progress and some of the research on choosing wisely that's going to be published by Health Affairs today. And as Rich described, I think choosing wisely was this seemingly simple and very elegantly designed idea and campaign. And we've been at this now for 5 years. I'm not sure if it seems shorter or longer to you. And we at the Robert Wood Johnson Foundation really see it as quite an important effort. There are several reasons that we feel that way. First of all, as Rich pointed out, it's really helped to kickstart not just a local but a national conversation about overuse of unnecessary tests and procedures. And as we know, these unnecessary tests and procedures lead to wasted resources and they lead to unnecessarily high costs, but they also very importantly have a high risk of causing harm. So as we all know, this is a really important conversation for us all to have. And there's a thread that runs through choosing wisely, which is conversation. And we find that when patients and providers actually talk to each other and talk about where the evidence is, what's important to patients, what kinds of shared decisions can patients and providers come to, what are the priorities, and then you really get quality care, and you get care that's evidence-based and that's centered around the patient's needs and wishes in a conversation with their provider. Of course, sometimes we are all patients, might want care that's not necessary by evidence-based, and that's also very important conversation for patients and their providers to have, and that also enhances quality. We've been really proud at Robert Wood Johnson Foundation to have been able to support community efforts to really bring these choosing wisely recommendations to life. And as Rich talked about and as Alan alluded to, that's where it really happens. It happens when really at the coalface where you really start to implement the recommendations. And it's been really wonderful working with the foundation and Consumer Reports to do just that. So I think that today we're going to have the chance to hear what happens about choosing wisely locally. What really happens when communities that have embraced choosing wisely, what happens as they implement it and they have been able to make real progress in providing appropriate health care to their patients. And they have been able to promote these all-important conversations that we've been talking about. And we know that these conversations happen at the local level. They do not happen at only the policy level. They do not only happen in DC. They happen in communities across the nation. Now, we know that it would be nice if we implemented choosing wisely and everything were just wonderful and we didn't have to do anything else and it would cure all. Unfortunately, that's not the case. We know that it takes a lot of focus, it takes a lot of commitment to change behavior and to change culture. And we also know, as in many things in life, communities get out of choosing wisely what they put into it. The more that they are committed to it and the more people that they have involved and the more leadership commitment they have, the more return they see. So speaking about communities, on the next panel, you'll hear about our grantees in Maine, California, and Washington State. And I think you'll hear a thread of many similarities in their stories, but I think it's also going to be very interesting to hear how different their paths have been, because as we know, each community is unique and each community faces its own roadblocks. And we have found with this work, as we have found, and probably many of you in the audience have found, that real learning happens when communities talk to each other, peer to peer. And these communities have really built up trust with each other, and they're able to show where they stumbled or where they made mistakes as much as where they found success. And I think that real learning comes from that. So as I said, this is a really important and critical initiative, but it's not enough. In order to improve the quality and value of health care for all Americans, we need to continue to commit to choosing wisely, and we need to continue to commit to reducing waste and overuse in the healthcare system. This was true at the beginning of the campaign, and it remains true today. And this commitment is really an integral part of Robert Wood Johnson's foundation commitment to build a culture of health in the country. And a culture of health, just very simply, is a society in which each of us has equal opportunity to live the healthiest life we possibly can, regardless of our circumstances, and certainly regardless about whether or not we happen to live in one of the grantee communities of choosing wisely or not. So the work continues. There's a lot of uncertainty that's happening in healthcare today. That's not a surprise to many of you, and it's nearly impossible without going insane to try and keep up with the news. But I think that communities represented here today are showing that in this endeavor to reduce unnecessary tests and procedures and to avoid avoidable harm, if you put the right amount of effort into it, you really can make a difference and you really can have success. And so I look forward to hearing from the communities and to hearing from the other speakers, and thank all of you for joining us this morning.
Good morning. Thanks to Alan, Rich, Susan, and all of you, and also to the staff at Consumer Reports that's worked on this project, Becca Rothschild and Dom LaRusso, who were somewhere out there. There they are. Consumer Reports is an independent, nonprofit organization that works side by side with consumers to create a fairer, safer, and healthier world. For 80 years, we've empowered consumers with trusted knowledge to make better choices about products and services. That's been our goal in healthcare and in the Choosing Wisely program, to encourage people to think of healthcare as a consumer good, providing everybody with the opportunity to make informed decisions about healthcare and the healthcare of their families. We encourage people to ask questions like, what are the risks? Is it safe? How much does it cost? What happens if I don't do anything? Our role in Choosing Wisely has been to serve as the lead consumer communicator in the campaign, developing educational materials based on recommendations from more than 70 medical specialty societies. As part of this role, Consumer Reports engages a coalition of consumer communication partners, including nationally known hospitals, health systems, and nonprofits. We've also created more than 150 patient-friendly Choosing Wisely resources around topics such as giving children unneeded antibiotics for a common cold or pink eye, or taking unneeded opioids for back pain or a migraine headache. These materials tell consumers how they can question and avoid unneeded treatment so that they can avoid both unnecessary expenses and potential risks and harms. The materials include information on what to do as opposed to simply what not to do, and they're freely available to the general public in both English and Spanish and to healthcare providers. And guess what? Consumers are changing their behavior. We have new findings from a survey of more than 4,500 Consumer Reports subscribers who took their Choosing Wisely wallet cards to their doctor appointments and asked some or all of the questions on the card. 20% said they changed their opinion about what to do. 22% said they changed their plans about an anticipated treatment. 88% said that their doctor was open to answering questions from their wallet card. 90% said they would encourage their friends and family to ask these same questions. The bottom line is that consumers are challenging cultural norms around medical overuse and engaging doctors in conversations, which is the real key to choosing wisely. Thank you.
Great. It's a great introduction to the topic. Let me just ask a couple of questions. Rich, I was struck by your phrase, it's turning the guidelines process on its head. When I think about guidelines, the next thing I think of is accountability to follow. And I'm trying to think about the balance between all the voluntary structure, which is part of what gets buy-in, with the question of accountability on the back end for actually choosing wisely. And so I wonder if you and maybe others can speak about where does the accountability play into this?
Great question, Ellen, and a lot of ways to think about what you're asking and how to answer it. You can have the idea behind what we were trying to do was, as we said, to start conversations and create tools. The part of the reason I think Choosing Wisely took off was that it happened at the same time that we were first starting to talk about triple aim outcomes as a goal in healthcare. And you might ask, well, who's responsible for achieving triple aim outcomes? And you could say, well, it's in the National Quality Strategy, so somehow it's the federal government, or somehow it's all of us, or somehow we need national data. In fact, I think what's happened with Choosing Wisely is, just as it was an engagement strategy, implementation has gone downstream. So we get data from individual health systems that have implemented in an accountable environment where they've got risk-based contracts or they're operating on fixed budgets, and they say, we implemented these guidelines and saw these kinds of changes. I think it's fair to say that lots of times in research, you're doing a trade-off between a highly controlled environment which gives you very robust conclusions, but they may not be as generalizable once you leave that environment. If you take something that's designed to operate in a whole variety of different environments, you give up the idea to precisely quantify what happened, but you invite each of those environments to study that. And with Susan's help and the kind of work that we were just hearing about from Consumer Reports that Jessica was describing, I think there's lots of examples of that accountability being achieved, but we haven't, as a foundation, said we're going to collate all that and make some broad statement. I don't know if you have thoughts.
I really agree with that. I think one of the most interesting aspects of this work is just how it gets implemented, not only in each community, but often in each system. And I think that we have been able to find and really curate some fantastic resources and guides as to how organizations and providers have implemented this. And as Jessica talked about, how are consumers actually using this information? You know, it takes two to tango. And if you have an informed consumer who comes to a provider who's not open to discussing the kinds of choices that the consumer or patient needs to make, that's not going to work. But you need both of these parties to be informed and to be accountable for taking part in this shared decision. So I do agree with that. The downstream implementation is where I think this really comes to life.
And I think the evidence that I cited, it doesn't get at ultimate outcomes, but it's pretty good evidence. We have pretty darn good survey evidence that I cited, and we have enormous amounts of additional anecdotal supportive evidence that our very good staff out in that row right there has been collecting. And so, you know, maybe ultimately we do want to study it in a more rigorous way, but this is pretty good proximate evidence.
Let me close with one more question. Susan, you used the term conversation. It's the thread, and clearly this is about conversations. Jessica, you mentioned a wallet card to take to a clinician visit. We have a lot of examples of efforts that ask for conversations to happen in the physician's office that don't go so well. They don't fit into the workflow. They don't fit into the 15 minutes or 7.5 minutes. And so my question is, where else are we looking for this conversation to take place so that we don't put all the pressure in an already over-pressurized setting?
Well, many of these decisions are made with one's family. So I think the wallet card serves, I mean, there's many people that you consult about whether to obtain medical treatment, not just your doctor. So I think the wallet card and other materials we provide is designed to crystallize decision-making that you make across many channels.
Are there other conversations that you all are supporting in helping take it to families and others?
Yes, and we and both ABIM and Consumer Reports have been working very closely also with a network of consumer groups who reach a range of constituencies in a range of venues and in a range of different ways and in a range of languages. And I think that using, besides at the individual level, the family level, and the community level, I think that when we use these intermediaries as well to raise these conversations, because these are issues that are not just important to us as healthcare people, but clearly important to individuals. It impacts their health.
And if you take various kinds of tools like a fall risk questionnaire or a PHQ-9, you're dropping them into a clinical encounter. That's not continuous with an actual conversation. These are things that empower consumers, that when somebody says, I think you should do X, the conversation they're having is, should I do X? So it really fits into the conversation. It's more about empowerment for an existing conversation than it is about dropping in a new conversation.
So I just, that's great, and I just want to quickly, Jessica, at the end you had an important phrase, it's not just what not to do, it's what to do. So how do we turn this message of don't into something positive? Can you
Well,
give an
I think
example?
that many of our materials contain, Becca, do you want to give an example since you're sitting right there?
So one thing we've learned is that if you tell healthcare consumers what they should do, what's broken, they always want to know what to do. They're taking time off from work, they're coming to the doctor's office. So for example, if they bring their child in with a cold with a runny nose, and we're saying no, antibiotics are not the answer anymore, we must put antibiotic resistance. We also let them know that perhaps if they just go home, they rest, they drink tea, do other things that have been proven instead of antibiotics, that they will get better just as quickly without putting themselves in harm's way of what antibiotics can do when they're not needed.
So since we're videotaping this and those watching didn't hear any of that, Jessica, can you give a quick synopsis of what your
So,
colleague
for
said?
example, when you take your child, so one of the things we tell you not to do is give antibiotics to your child that may just have a virus. So then we also give the same advice in terms of what to do, which is the advice your doctor inevitably tells you when you go to the doctor with a virus, which is to rest, to drink fluids, to stay in bed. So it's also a to-do.
Very good. Thank you.
Thank you.
Please join me in thanking our opening panel for a great introduction.
Nice meeting you.
And I'll ask my what has been accomplished panelists to join up here. We'll move seamlessly into the next segment, if they can move seamlessly up to the front. Our next panel is going to look at what has been accomplished with the campaign. We're going to hear from Eric Weil, Interim Chief Quality Officer for LA County USC Medical Center. He's also an Assistant Professor of Clinical Emergency Medicine at the Keck School of Medicine at the University of Southern California. We'll hear from Matt Handley, Senior Associate Medical Director for Quality and Safety for Kaiser Permanente of Washington. We'll hear from Kellie Slate Vitcavage, Project Manager for Consumer and Community Engagement for the Maine Quality Counts Northern New England Practice Transformation Network, and from Arthur Hong, Assistant Professor in the Departments of Internal Medicine and Clinical Science at the University of Texas Southwestern Medical Center. We'll turn it over first to Eric.
All right. Thank you for the...
Feel free to come up if you like.
Oh. Sure. All right. Thank you for the kind introduction. So first, I'd like to thank Dr. Barron, Daniel Wolfson, the entire ABIMF team, as well as Alan Weil and Health Affairs for putting together this very important event today and giving me the opportunity to share our Choosing Wisely journey in Los Angeles. So I was asked to cover a few talking points. I think they're worried about people from Hollywood going off script. So why choosing wisely? Barriers that we've had to overcome and some of the successes in the safety net setting. So why choosing wisely? I believe the true question we should be asking is why not choosing wisely? No matter how you measure low-value care, whether it be the $200 billion annually to our healthcare system, delays in care due to backlogs, false positives, incidental findings leading to more unnecessary care, or actual harm to patients due to errors, side effects, and bad outcomes to the tune of 30,000 deaths a year, we simply cannot afford to not address this critical issue. This is even more pronounced in the safety net setting where resources are limited. If there is a 9-month backlog for outpatient MRI, because everybody with low back pain has an MRI ordered, then people who truly need that MRI for time-sensitive diagnoses such as cancer are suffering. So Choosing Wisely has had numerous successes over the past 5 years, and I can't possibly do that justice in my brief comments here. Over 80 professional society partners, 450 recommendations, 29 past and current grantees, countless hospitals, health systems, statewide collaboratives, and numerous partners such as RWJ and Consumer Reports. I only have time to briefly tell you about our journey as a Choosing Wisely grantee. As a collaborative between Los Angeles County Department of Health Services, Department of Public Health, UCLA, and Consumer Reports. So LAC USC Medical Center is the flagship hospital of Department of Health Services in the County of Los Angeles. We have 600 beds, a level 1 trauma center, a burn unit. We see about 175,000 annual ED visits. It's famous, or maybe I should say notorious, for Code Black. So our team selected 3 Choosing Wisely initiatives in a patient-facing survey. So initiatives were to reduce preoperative testing for patients undergoing cataract surgeries, and we did this using the IHI model for improvement with rapid cycle tests of change. The second was reducing advanced imaging for low back pain, where we implemented a clinical decision support tool into our EMR, as well as audit and feedback. And our third was reducing antibiotics for viral bronchitis. Here we did a big education campaign with our urgent care providers, followed by a public attestation on gentle nudge posters. And now when they're sitting in a patient care room, they have their smiling mug and their signature facing them, reminding them that they promised not to give antibiotics for viral bronchitis. So some of the barriers that we've run into at LAC USC are the well-established culture. I cannot tell you how many times I've been told, this is county, this has always been county, don't you dare think that you could ever change county. Clinicians feel overwhelmed, and Choosing Wisely feels like just one more thing that we're asking them to do. Our residents nearly rioted after radiology clinical decision support module was added to the EMR. Just a few more clicks. How many times have they heard that? And finally, which I'm sure is going to be absolutely shocking to all of you, physicians don't like being told what to do. So I'm going to share you one of our success stories, the preoperative testing for cataract surgery. So this epitomizes low-value care. The surgery does not require anesthesia, takes less than 15 minutes on average. However, we, like many other hospitals across the country, were getting a full panel of laboratory studies, chest x-rays, and electrocardiograms on these patients. This meant additional visit to the hospital, incidental findings, false positives lead to more visits, more care, more testing, and ultimately long delays until surgery. So by using the IHI model for improvement, attending resident physician champions from anesthesia and ophthalmology, and showing the clinicians the data that not once did preoperative testing change the ultimate management of cataracts, but often led to delays. We were able to get buy-in from the residents, from the frontline providers, and dramatically reduce preoperative testing. So as you can see from this graph here, LAC USC Medical Center is the red line, and our sister hospital, Harbor UCLA, is the blue line, which we're using as a control. You can see an 80% drop in preoperative visits for cataract surgery. On the next graph, these are pre-op EKGs. Once again, about 80% drop. Laboratory studies and chest x-rays show similar significant decreases. So you don't need to be a stats expert to see that there's something happened, something changed. But how does this translate to value for our patients? So prior to the implementation of this Choosing Wisely initiative, our median wait time for cataract surgery was 245 days. Afterwards, it was 64 days. So this meant, on average, our patients had 6 months of improved vision. So that is something that you could take home. So what are some of the next steps for us? In California, we have a collaborative called Smart Care California, and they're addressing a lot of the Choosing Wisely initiatives with low-value care. Many of our Medi-Cal waiver, otherwise known as PRIME, participating hospitals are adopting Choosing Wisely recommendations to help them meet the waiver metrics. And at DHS and LAC USC, as well as at UCLA, we are continuing on our journey of laboratory radiology and procedural stewardship to reduce waste and to improve value for our patients. So I wanted to take a quick moment to thank Daniel Wolfson for his vision, his leadership in creating Choosing Wisely. And once again, I want to thank ABIMF, Robert Wood Johnson, Health Affairs, and Consumer Reports for the opportunity to share some of our successes at LAC USC. Thank you.
Hi there, my name's Matt Hanley, and thanks for the opportunity to share some perspectives on Choosing Wisely. I'm going to talk from two different perspectives. I'm the Medical Director for Quality and Safety for Kaiser Permanente of Washington, and then the other kind of lens I want to put on this is I'm the Chair of the Washington State Task Force on Choosing Wisely. So at Kaiser Permanente, we have a long history of working to reduce low-value care. In a way, we almost have an embarrassment of riches. We have integrated multi-specialty group practice, integrated care and financing. We have a culture of having patient at the center for design of care. So all the things are aligned. In some ways, it's supposed to be easy there. And it's still hard, but we do have a lot of advantages. We're used to thinking about the harm we expose patients to as part of the equation when we think about organizing care, and also we're not afraid to talk about cost. We know that our patients want to talk about cost. It's an important barrier to care, and it's an important consideration that they always bring. So we want to be able to add that to the conversation also. One thing that Choosing Wisely has really added is, in addition to all the work we do with our clinicians, this helps us because clinicians are engaged by their specialty societies and asked to reflect on the appropriateness and necessity of the care they offer patients, which we think is a great value to us. So when I thought about how to approach my comments today, I thought one thing is to talk specifically about some of the successes like we've just heard, but I chose to go a different direction to kind of talk about how we've organized our efforts. And one of the things we've done that's been helpful is we've recognized that there's two complementary approaches. One is the technical change, how to implement, and the other one is the culture change. And that word is going to come up all morning, I'm sure, because culture eats strategy for lunch. If we don't get culture right, we won't be successful. The technical piece emphasizes basically taking implementation science and applying it to de-implementation. We know how to do that. It's complicated but not complex. Remember, complicated is getting a man to the moon and back. There's a lot of math involved, but if you're good at math and you cross the T's and dot the I's, you can do it successfully. Whereas complex is nonlinear. It's like raising a child. Every decision you make changes the future in a way you can't predict. So the technical piece is complicated, but we know how to do it. We always start with why to get engagement of our clinicians and our patients. We work to understand the specific barriers to change and influence those. We make the right thing the easy thing to do through workflow and technology, and we use transparent peer comparison data to help drive improvement. But we've got to be careful there. It's easy for that to fall into an exercise in shaming. And while that gives you a short-term gain, that erodes the culture you're trying to build with physicians about continuous improvement and a learning organization. So we're very attentive to that. We believe that the best resources our clinicians have is each other. Because if you can match the performance of the best in your group on all the different aspects of care, you'll have the best outcomes anywhere. And the way that happens is for people to see who's cracked the nut and who's figured it out so they can have conversations with them and spread that learning across our group. We often say no data without stories, no stories without data as a big driver for culture change. And culture change is hard. It's complex in that true sense. But if we get it right, It allows an amplification past the specific reductions in a Choosing Wisely measure towards reflection on our broader practice of medicine, which is what I think we're trying to do. This is the Choosing Wisely strategy of recommendations is a great start of that conversation. But ultimately, we want to end up with more reflective practice that is more patient-centered and recognizes the outcomes that are important to patients and involves them in their care. Our culture is defined by those shared stories, so we share a lot of them about the conversations. We share the conversation about the quadruple aim, about better patient outcomes, a better care experience, more affordable care, and a more rewarding clinical practice for clinicians, because we think these conversations are actually a lot more interesting than clicking on a prescription. When I back the satellite up and think about the state Choosing Wisely task force, there's some interesting stories and learnings. So we created a state task force 4 years ago with the support of our State Medical Association and the Washington Health Alliance. And the Health Alliance is a collaborative effort that brings together payers, purchasers, providers, patients, let's see, all the Ps, basically everybody. And we've got stakeholders from all of those participating in the task force. They also have a great investment at the Alliance. They have an all-payer claims database that includes almost all the commercial claims and Medicaid claims for the state for the last 10 years. And what the task force did was go from the recommendation for 11 different Choosing Wisely topics to actual technical specifications, which is really hard. It turns out that's one of the challenges people have is going from an idea to a technical specification that you can get alignment around and buy-in and then measure for improvement. When we applied those technical specifications and queried the data in the all-payer claims database, we saw what you might expect. We saw variation in our state that could not possibly be explained by differences in clinical circumstances or patient preference. And we found something else that's interesting. We found that for 2 of the metrics, they almost never happen in Washington State. So you've got to know your own data before you commit resources to a change. I know that we haven't done a pre-op test for cataract surgery in decades where I work. We don't want to work, everybody has a different problem to solve. The other thing that the task force has done is do a great job of promoting conversations between leaders in different organizations and sharing best practices. So we've got better conversations with patients. We've got better conversations between peers. Our data show that our clinicians are more comfortable talking with patients about this than they are talking with each other about this. And we have to crack that nut because that's the flywheel effect that we think we'll be able to get going through culture. The last conversation that we want to be having is the one we're having today, which is the 4th level conversation with patients, between clinicians, with leaders in health systems, and then in a broader policy framework so we can figure out together how to accelerate the work.
Thanks, Matt. I'm Kellie. I'm your grassroots organizer on the panel today. I'm used to being out on the road, in the streets, working with people, pulling my sleeves up, and really having the conversations. At Maine Quality Counts, one of our strategic priorities is to create meaningful consumer engagement. So we started a large conversation among patients, physicians, and other healthcare providers about sometimes less is more. And we did this through the smart language and messages through Choosing Wisely. Our overall intent was to create cultural change in the community and couple it with system change. So we first started with system change, with working with our health systems that we were involved with in the state of Maine. And just to give you a story on what's really happening, it's a microcosm of what's happening across the United States and what's occurring in Maine. Tazra Tessier, she's a physician assistant up in Bangor, Maine, and she really wanted to grasp this issue with her patients on the proper use of antibiotics. And so she started out trying to educate her patients. She sees 18 to 20, 25 a day, to try and help them understand the difference between the use for an antibiotic for a virus versus bacterial infection. And at first, all of her patients were very reluctant in this endeavor because they didn't believe her because they were always receiving antibiotics and they always felt better. So she felt more compelled. How can we really move the needle on this? And so she thought, let's work with Maine Quality Counts and figure out visual depictions of choosing wisely, the 5-question posters. They weren't satisfied with 8.5 by 11 or 20 by 18. They wanted 3 by 5 foot posters that they put into their waiting rooms. They put a little bit smaller ones in their exam rooms. But then they thought, we need these out in the ER. We need these in our walk-in clinics where we can have people be confronted with that message, that cultural message. We needed to get outside of the clinical walls, so to speak. And so that's really where we started putting things up. We kind of creeped into the outside of the exam room, into the walk-in clinics. And then last year, she started noticing a huge difference with her patients. They completely understood, I understand I don't need an antibiotic. However, I'm just coming in because I want to make sure that everything's okay. That's huge. And so to see that change, we then took the effort to taking this out, what I call the streets, and really working with our community, and really taking a look at connecting with key community partnerships. They could be your area agencies on aging, they could be your consumers for affordable health care at the statewide level, our non-traditional partners that we're not used to working with. We traditionally worked on the clinical side, and so we really needed to push this effort out into the streets and work with those community support organizations who are really changing the culture of health out in our communities every day. And so that's what we did. We built these partnerships. We worked with everyone in a very organized manner on a monthly basis, looking at that true community organizational work. What does it take? How to keep the momentum going? How to keep the action steps in front of us so that we can continuously scope and do social networking mapping. Who knows who can open up what door, who can spread that message for us. So we started small, like the small spoke of a wheel, and gradually got larger and larger so that we were affecting more people on a daily basis in community organization supports where they receive supports and education, but Choosing Wisely was integrated into that. So that's really what it took, looking at different partnerships, different multi-stakeholders, whether that be on the clinical side with our physician champions, our provider champions, our patient champions, our consumer champions. We have employer champions, and really the support that it takes to keep everyone connected. There's one of me, and I am in the state of Maine, so it's quite the challenge, but it does motivate you to figure out who you need to connect with to push that message out about choosing wisely. We had conduct focus groups early on, about 2 years ago, so we have seen the needle move forward a bit there as well, because most of our consumers were afraid to even ask a question in their visit. They trusted their doctor. And in Maine, it's hard to get to a new provider. We have such shortage that was just compounding the issue. So we felt that, we're the pioneers in this effort. We're going to get our knees scraped a little bit. We are educating our clinicians out in the field. But we need to be there as well. We need to be in the driver's seat as a patient, as a consumer. So we're going to get our knees scraped a bit. So that's what we did. We looked at those barriers. We started working with other community organizations that can help us reach people who in our older adult population tend to have a little bit more difficult time reaching out to their caregiver groups to spread that message around on Choosing Wisely. The results of this effort really have been that we have culminated several health systems, over 30 practices that are primary care, 4 walk-in clinics, 4 ERs that have been involved. We work with over 900 providers on Choosing Wisely in Maine and are always targeting around 9,000 physicians on a basis of working with our medical societies. And really, we've really started the issue of getting out in the community with over 90 plus events, reaching over 130,000 people with over 100 or so targeted media message that we don't pay for. So we're really trying to always leverage our work that we're doing since there's not a lot of staff involved. So really, what are our next steps with Choosing Wisely? We're looking at the sustainability. We want to work more with our employers. We have 2 key champions, Bath Iron Works, and we also have SMRT, Architects and Engineering. And we're looking at how deductibles are rising. And we really need to figure out how we can help our employees and employers in Maine work with their employees to make smart, effective care choices. And so they are opening their doors to us with our Choosing Wisely message. We really feel that's where we need to reach our next rendition of our patients, consumers, those who are very concerned. I really can't afford this. What are my other alternatives? What if I don't do anything? And so that's where we're taking our message now, and we feel that that's part of our sustainability and the message that we need to bring forward. We're working also with what's happening in the community. Right now, we're all involved in seeing flu clinics occur. So we created a flu care package because you don't really need the antibiotic, but here we care about you. We want you to feel better. And so here's a little something, as well as education on proper use of antibiotics. So we had to confront some issues. Organizing community groups, working together non-traditionally, having some time to work around those issues. We needed to concentrate on how we could keep them motivated, how we could adapt our materials. I think our central tool we created, the wallet card is great. This is the 5 questions of a RAC card. Our partner said, Kelly, that's not working for us. What can we do? What can we create? So adaptation is key, diversification on some of our materials with the photos of the audience, and then keeping the momentum and creating new linkages are very important in our work. So we already have learned that engaging patients improves health and health care. Patients without the skills to manage their health care incur costs up to 21% higher than patients who are highly engaged in their care. We know this through the work of Susan Mendez and the work at Robert Wood Johnson Foundation. Back in March of 2014, there's a great Quality Field Notes issue brief. It's called Engaging Patients Improves Health and Healthcare. I ask that you may want to take a look at that. It's very important in the work that we're doing. So lastly, we really need to understand that social movements do take time. We are now beginning to reap the benefits and are shifting cultural attitudes towards our healthcare on a personal patient, consumer, and employee level and healthcare system. So I hope that we can continue this conversation on a larger scale, that sometimes less is more. Thank you.
Good morning, everyone.
Send this down.
Oh,
Peter,
sure. Should I go up? Sure.
Yeah, come on up.
Morning, everyone. So Choosing Wisely started April 2012. That was just before the beginning of my residency. So actually, it was a very visible part of my clinical training. And towards the end of it, I wanted to see whether we had made progress, whether we were just preaching to the choir in some sense, or whether we were starting to move the needle nationwide. So when I was looking for research projects to do as a research fellow, I thought about looking at this, and I focused on unnecessary back pain imaging, because this is actually a very visible part of the campaign initially. It's a very common issue that people come to the doctor for. Imaging is pretty well known to be expensive, but it's not really such an urgent situation that the clinician kind of dominates the decision making. So I thought it would work nicely to take a look at seeing whether we had made progress here. This is a bit of a complicated graph, but I'll break it down. Basically, what I looked at was the trends prior to Choosing Wisely had started, predicted about a 23% rate of imaging. But when we looked at what was actually happening, we got about a 22% rate of imaging. This was about 2.5 years after the start of the campaign. So, 1% drop or a 4 percentage point difference, however you want to couch it. The real question for me was, who is doing the choosing? Is it the doctors? Is it the patients? And it occurred to me that the patients who might be most interested in avoiding this unnecessary imaging are the folks who are the most financially motivated. So I started to think about patients in high deductible health plans or consumer-directed health plans where they're responsible for the first, at this point, like several $1,000s of their care. And was wondering, the rhetoric around this is, this is going to unleash consumerism. People are really going to be using the information to avoid unnecessary care. And it occurred to me that if anybody is using Choosing Wisely to avoid unnecessary imaging, it should be these folks. Unfortunately, I didn't see a statistically significant difference between the two groups, the people in the consumer-directed health plans and the people not in the consumer-directed health plans. So I think it illustrates some challenges. And if I think about how clinical practice works, so you have the expert, the clinical expert who's the clinician. Not only do they provide a recommendation, they're in charge of explaining even what the options are. right? And the patient does end up paying the cost. But when so much of the decision-making authority is held by the clinician, it really makes you wonder who the shopper is that you should be targeting. The other thing that occurred to me is that when you ask doctors about why unnecessary care happens, number one is usually malpractice fears, malpractice boogeyman. Number two is this idea that patients are demanding imaging, which is a kind of weird feedback loop. And so I think really what's very powerful about Choosing Wisely to me is that it's almost a public health campaign. That you need to talk to the wider public about the idea that more care is not always better, that the right care is best. And that's a difficult topic to broach. It challenges clinicians even. I wanted to end with a story. A few years ago, I was seeing a patient who had come in for acute back pain, who's in his 40s. And sort of a few minutes in, he let slip that he's a radiologist. So I sort of, straighten up. And then he says this thing that sort of catches me off guard. He says, I know the evidence on imaging shows that it doesn't really improve pain. And then he sort of trailed off. And I was like, okay, yeah, that's correct. We'll talk about it later. And throughout the course of the visit, he brings it up like 3 or 4 times, and I'm not quite sure what's going on. But I'm starting to realize that this guy's asking me if he can have imaging for his back pain. And he doesn't know how to ask because he's in such excruciating back pain. He wants something done. And I think several people have brought this up, that this isn't just a campaign of saying, like, we don't do this. It's about, we know this doesn't work. But part of the conversation should be, if not this, then this. And that was really the difficult thing for him. So I said, you're just taking ibuprofen, let's do that, and Tylenol. We have physical therapy at the end. And I also talked to him like he was a regular patient. I said, here are all the reasons why we might get imaging. Here's when I examine you, why I'm reassured. If anything changes, we can change our management. And that actually worked for him. And I never actually broached him about this issue of, were you asking me for imaging? But it was striking to me that even this guy knows the evidence. This guy sees it all the time. And it was still a difficult situation for him to grasp, because he really wanted some reassurance. He wanted some relief. And I think that's something in medicine we're actually starting to realize again, that that's a lot of what we provide. And that if we can do it in a very judicious way and not cause downstream clinical harm with all this care, I think that's going to be a very powerful thing we can do. Thank you.
We're not taking the break yet. A couple of quick questions, and then I'll open it up to those of you in the audience. Start with Eric. You began, we wanted you on script to say why, and you said why not. And I think that's a great answer. But then you have a comparison hospital that didn't do what you did. So there must be a why more than just why not. So I'm going to push you a little more about the why.
So I'm pleased to say that Harbor UCLA is now adopting what we're doing at LAC USC. So,
and that may have something to do with the why.
Yeah, it's hard. Yeah, exactly. Hard to argue with the results. No, I think everything that's been said with the introductory panel and my co-panelists up here just further reinforces the why this is so important. It's the cost to healthcare, it's the delays, it's the harm that we're actually causing to patients. And my sentinel Choosing Wisely or low value care case was a young female that I saw that was put on Bactrim for a completely inappropriate reason, and she ended up with a bad skin reaction called Stevens-Johnson syndrome, and ended up in a burn ICU just because some clinic doctor thought Bactrim would help her stomach pain. I think we all have tens to hundreds of anecdotes, but on a larger scale, this is not sustainable.
Thank you. Matt, you began with our patients want to talk about cost, and that's actually something we don't hear very often. That's a different environment, and I go to Arthur's comments at the end about patients demand it is sort of the mantra. So is that a lot of people think that's sort of a self-selection issue at Kaiser, but I also wonder if it's a culture, an intentional culture that you all have tried to create that then makes these other conversations easier.
What we do, we train clinicians about communicating about low-value care, and we do specific training for that. We find it fascinating that the demand for care of some kind is almost always an uninformed request. So we see it as a partially informed request rather than an antagonistic demand. Even using the word demand mischaracterizes it in a way that makes an adversarial conversation rather than patient. It's like when people see drug ads on TV, it says, ask your doctor. They're just asking almost all the time. And when you have a conversation, they're curious, as anyone would be. It's like when they ask Dr. Google and they bring things in. It's not that they're demanding. It's that I have questions. Might this be right for me? So demonstrating empathy first and foremost in conversation, and then understanding what the patient actually is interested in and working to improve clinician skills in those has been really effective.
Something tells me all those ads that say, ask your congressman if they support something, have a different agenda. Kellie, you started out and said, I'm a community organizer, and you discussed interactions with other organizations. What kinds of organizations are aligned with the goals that make it possible? How does that conversation begin?
Well, as an organization, we are independent and we try to align our activities with anything that's out there, such as, one example is the opioid epidemic. We're working, choosing wisely, integrating that into the work and the education to our clinicians across the country, or across the state of Maine. And how that happens is that we start calling them up. We also take a look at what their interests are, so we meet them where they are and can we help them achieve their goals. And so doing so, we look at the audiences we want to serve, which best community groups serve that audience so that we can all be successful. So it's always a win-win. And how can we, the ultimate aspect of that is how does the patient or the consumer win in that? So we do need a cross-section of clinical participants, such as our medical societies. Both the Maine Medical Association works with us and Maine Osteopathic Association. We work with our nurse practitioners, we work with our PAs. So we have the system approach as a stakeholder. They've been with us since the very beginning of Choosing Wisely, but then we really needed to assess the community partnerships that we need to reach out to continue that culture of health in our communities. We do that clinically with our quality improvement initiatives, and this is one of the areas that it's a natural for us to fit into.
Arthur, this is a bit of an unfair question, but I'll ask it nonetheless. You picked this dimension of high-deductible health plans, consumer-directed health plans, sure, as a hypothesis for where you might see difference.
Yeah.
Null results are nothing to be ashamed of. We publish them, as you see. But my question is, with a few more years of thinking behind it, and given your comments about where you think patients want to be engaged, if you had a different dimension now, if you were redoing this and you said, I think it might break out along this dimension or that dimension, are there other differences you might think of that would lead to a more likely to have an effect and less likely to have an effect?
So I think where it might seem to work is if you can get patients and you can get them the right information about, okay, I need an MRI, where is the cheapest MRI? But I think this is a really difficult one because every granular clinical scenario, I'm not quite sure how much you can task the patient to be responsible for attaching that. I think really the responsibility honestly lies mostly with the clinician. I think Matt's point is really, I want to echo, is really important about what clinicians mean when they say patients are demanding something. Over the course of my training in medical school and residency, you shadow a lot of different clinicians. You see how they operate. I was shocked to see how many times a patient would just ask, and the clinician would interpret that as, if I don't order this, they're going to sue me. And they told me that. They said that that's what I should do. And I'm not quite sure where that behavior gets learned from. And I don't think that's unique to where I was training. But I think that's really the nugget, and trying to partner that with patients being responsible for their care. I think that might be where you move the needle. The difficult thing is that the high deductible plan doesn't really account for whether you need an image or not. You're still paying full freight. That's a very difficult situation that I think needs some remedy. I've had several patients who've actually talked to me and said, I have a high deductible plan. Please only get this imaging if it's necessary. And I still had to get it. But, you know, I wish I could give them the money to recoup that cost. I think that's a real big problem.
We have some time to engage you. As I noted earlier, this is being videotaped, so I'd ask when you ask a question to wait for the microphone and to identify yourself. And let's go ahead right here.
Catherine Capps with Health 2 Resources. I'm particularly interested in the resource consumption question, both as it relates to the clinician and the consumer, because I think it's an interesting conversation, and I applaud what you're doing in Choosing Wisely, because I think those conversations are important. But as we move forward and look at the issue of resource consumption, both the knowledge that the clinician has of that and the ability to do that, and the consumer, I think that becomes an important area. So can you make a comment as it relates to the evolution of this relative to that?
If I may, we're also involved in a cost of care initiative program, and that's really getting at the consumption of resources. It's part of that conversation between the patient and the provider in regards to imaging. What are the other options? And creating transparency on some of the other treatment options that might be available, and having that joint decision-making process, whether it be PT or advanced imaging, or really realizing the guidance of the provider, however, bringing the patient in so that they're more engaged in their care and creating more transparency. And also working with transparency cost websites like Maine. We have comparemaine.org. We really need to educate our patients and our consumers on these tools and educate them on how to spend their healthcare dollars wisely. So it's a very important issue that we're working with.
One of the things that's been helpful for us is to approach this through that model of shared decision making, and recognizing that there's two aspects to many of these decisions. One is the medical problem solving, or what are reasonable clinical options, which clinicians need to do. And the second one is, what's the right treatment for me, given my preferences and values and my cost exposure? And separating that rather than lumping them together helps support that. We've actually published in Health Affairs our work on shared decision-making, showing, consistent with all the other studies, that when you have a program that supports shared decision-making and patients are more involved, you get a triple aim outcome.
Hi, I'm Dr. Caroline Poplin, and a primary care physician. One thing that worries me about Choosing Wisely is you focus on the procedure and maybe the indication or not indication, but situations are different. There was something I read about a little girl who was brought in by her father to the ER after she'd had a concussion playing soccer, and they see a physician they've never seen before, and they're thinking about a CAT scan. Well, generally speaking, it's not recommended. But on the other hand, the physician doesn't know anything about this little girl or her family or the soccer game. If she were going to a primary care physician whom she knew, then there would be no question. There would be, the physician would see she's fine, and the father would trust, and there would be no worry about malpractice. But when you have a little kid you've never seen before, you have no record, you have no background, you have nothing. In a case like that, if I were an inexperienced ER physician, I would do the CAT scan just to be on the safe side.
but there's clinical prediction rules. There's actually evidence about many of those things that can be more important, because the clinical prediction rule should apply whether you're seeing your primary care doctor or someone in an emergency setting. So evidence still matters. It's certainly clear that it's easier to reassure people in the context of a longstanding trust relationship. I've had a continuity practice myself for 30 years, and that's an incredibly valuable asset.
Yeah, and I could speak to that as a ER physician who sees kids, and I think it's all about the approach of the conversation. You know, I'm not your family practice, your long trusted physician, but I'm going to take the time to sit down and explain my thought process, my reasoning, the evidence behind my decision, and I found that to be equally successful with patients.
John.
Thank you for the panel. I'm John Rother with the National Coalition of Healthcare. Many of us in Washington have assumed that the key to overuse was changing financial incentives, moving to value from volume. Yet in your remarks, you didn't really emphasize that. The emphasis was more on culture change. I wonder if you could address how financial incentives play into this.
Well, sometimes a fish doesn't know it's swimming in water. I get to practice as a salaried clinician where I'm paid to take great care of patients and not more or less. I get a little bonus if I do high quality and my patients feel that I'm a good communicator, but I'm pretty much insulated from that. I have another role where, as a medical director in the health plan, also I go out to our contracted network. Great clinicians who are living in a fee-for-service world. And it is much harder to engage them in efforts to reduce waste than it is people who are not financially at risk for it. It's just a reality. And while we've made some small moves towards value-based payment, my experience is that if you're doing 10 or 20% of your day in value-based and the rest in fee-for-service, you haven't made a change that's substantive.
I'd also add that, I think there's, from what I've seen, a lot of the payments have affected bigger health systems with the wherewithal to sort of address these issues. The private practices don't respond as well, perhaps. But when you trickle down from those institutions to the individual clinicians, I don't know that they see a lot of that difference or that financial swing based on their performance. And I also think there's sort of a ceiling to that when you look at sort of what we know about behavioral economics and why people do the things they do. When people are working in environments that aren't just monetarily driven, they only respond so much to monetary rewards and penalties even. So it may have to be a mix of that plus other things.
We have one last question over here.
Becky Haynes with the American College of Radiology, and a longtime supporter of Choosing Wisely. Yay team. This is a question for Dr. Weil. How did you overcome clinician resistance to using your clinical decision support tool?
So I think we stumbled a bit because we had our providers making a phone call to the radiologist to vet orders. And when we rolled out the clinical decision support tool, we just added it on as something extra. So they had to go through the 3 or 4 clicks of the decision support, then pick up the phone and call the radiologist anyways. So to them, talk about not value added, right? Just one more step. But when we were able to take away that phone call, if they got to a green or a yellow on the clinical decision support, they're like, oh yeah, I'd much rather make 3 clicks than to have to, call, be on hold, wait for the radiologist to come to the phone, and then, convince them that I want to get this study. So taking something away and showing them value add, that's what got us over the hump.
So I think the theme is this is not taking away, whether you're talking about making it easier on the clinician side or giving the patient something affirmative to do that's not nothing. This definitely seems to be a theme that's coming out. Please, now I will put up the break slide and join me in thanking our panelists, and we'll move to a break. This next segment is entitled Where Are We Headed? We've had a very rich introduction to Choosing Wisely and then some insightful comments about implementation and what we've accomplished and what is left to be done, and that's the focus of this next segment. We're going to hear from Neel Shah, Assistant Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School, Director of the Delivery Decisions Initiative at Harvard's Ariadne Labs, and the founder of Cost of Care, which is a global organization that focuses on improvements in delivery systems. We'll hear from Alex Mainor, Research Project Coordinator at the Dartmouth Institute, where he focuses on evaluation of factors that affect the performance of accountable care organizations. John Mafi, Assistant Professor of Medicine in the Division of General Internal Medicine and Health Services Research at the David Geffen School of Medicine at UCLA, where he also practices and teaches general medicine and primary care. And Eve Kerr, Professor of Internal Medicine at the University of Michigan, Director of the Center for Clinical Management Research, VA Health Services Research and Development Center of Excellence. We have, as I mentioned at the outset, papers published contemporaneous with this event, as well as a couple of blog posts, and Neel is the author of one of those. I'll turn it over first to Neel.
I don't actually have slides. I just want to stand at the podium because it makes me feel powerful. So this section is about envisioning the future, but I want to reflect a little bit on what we've accomplished to help set that up. Modern health systems are set up in a way where patients basically can be hurt in two ways: when we do too little too late, and when we do too much too soon. And until about 5 years ago, the ethic of first do no harm was routinely applied to the former, and we retain this enormous blind spot to the latter. And there are a lot of reasons for that, but one of the core reasons is really, I think, baked into the way medical education had been traditionally structured, primarily around this value of thoroughness. Now, thoroughness sounds like a good thing. Of course, you want your physician or your nurse or your pharmacist to be thorough, but it was thoroughness above all else and at all costs. And the way that thoroughness was sort of operationalized, I think, is very revealing. So, the motto of the hospital that I trained in at the time was everything possible, period. Right? The motto of the hospital across the street was until every child is well. Every single case conference, every case report was about things that were exceedingly rare. And of course, we'd reward people for finding the things that are exceedingly rare, so they would go to extraordinary lengths. During morning rounds, during morbidity and mortality conferences, you'd be chastised for not doing the thing you could have done, but you'd never be chastised for doing the thing you didn't have to do. And of course, people can be hurt both ways. I think there are three honestly brilliant things about the Choosing Wisely campaign that led to a shift in all this. The first is that by calling the campaign Choosing Wisely, like sort of implicit in the language is a shift from this value of thoroughness to a much more precise value of appropriateness. That's the first thing. The second thing was a recognition that nobody goes to medical school to treat the GDP. Right? Choosing Wisely is not about a dense or abstract macroeconomic concept. It's about the patients directly in front of you. And then the third thing is it didn't require the development of a new base of evidence right away. 5 years later, we're going to hear more about it, but right away it was really about taking the existing evidence and reframing it to being not about evidence to act, but evidence to be more thoughtful. So for the last year, my colleagues and I at Cost of Care have been able to partner with the ABIM Foundation to think about how we embed Choosing Wisely into medical education, or how to accelerate that process. So I want to just highlight a few of the things that have happened along the way that I think set up where we need to go next. So the first thing that we had to do is sort of figure out what are the competencies to choose wisely. It's one thing to tell somebody to do something, it's another thing to tell them why they ought to do it, when they ought to do it, how they ought to do it. So we did that. We helped put together a learning network of about 500 really progressive clinicians from across the country, some of which are in the room right now. And we challenged them to apply their innovativeness and think about strategies and tactics that could actually move the needle in creative ways. And over the course of 3 years, we would do an annual challenge. We got 234 submissions in total from 14 different clinical disciplines. We brought in some of the largest clinical partners in the country and healthcare system leaders in the country, including the American College of Physicians, the Association of American Medical Colleges, the Leapfrog Group. And through that process, we were able to elevate a number of enduring ideas. So some were conceptual, like the SOAP V, which is, the SOAP note is one of the fundamentals that we teach in medical school, how to write a progress note, subjective, objective, assessment plan. And there was a group, actually a group from a couple of different medical centers that added the idea of embedding a separate item for value. You have to communicate what the value of that is as well, routinely. The idea of the Teachable Moments case series came out of this process. So now in JAMA Internal Medicine, there is a case series where they highlight case reports, not just for the super rare thing that somebody diagnosed, but opportunities. It's an opportunity to highlight harms from too much medicine as well. And then along the way, we got to a point of maturity where there are a lot of off-the-shelf tools too. So there's the American College of Physicians has a internal medicine curriculum that's been adopted by most of the internal medicine residencies around the country. My colleagues and I wrote a full textbook for McGraw-Hill for people who still use textbooks in 2017. And there are online freely available modules at the Dell Medical School in Austin and at the Cost of Care website. And in 2017, we're in a place now where we've established a foothold where appropriateness truly does seem to be the norm in medical education. We've got health system leaders and AMC leaders who've got dedicated roles to thinking about choosing wisely principles. The first dean of healthcare value at the Dell Medical School, my colleague Chris Moriades, my colleague Vinny Aurora at the University of Chicago has a dedicated role to sort of bridge the quality function of the academic medical center with the medical mission. And I think actually one of the shining examples of where we've gotten to in 2017 is that in just 6 weeks, 25 students and faculty champions from 25 medical schools are converging in Austin under Chris Moriades' leadership to think about how they can bring choosing wisely principles back to their medical schools. So I really believe, honestly, we've gotten to a foothold where we've got this professional norm. But for the next 5 years, it'll be really critical to figure out how we not only have a norm around appropriateness, but we get to a norm around appropriateness plus affordability. Because increasingly in 2017, not only are patients very financially exposed, but we now have tests and therapies in our arsenal that are extraordinarily expensive. And sometimes, as Arthur pointed out, things are both expensive and appropriate. And then what? And I think that it's critical that as clinicians, we own some of that. And as medical educators, we own some of that. There are probably things that we can do that are within our direct clinical purview, from thinking about therapeutic alternatives to thinking about just timing and spacing of treatments. There are things that we can do to activate resources within the clinical health system so that when we involve financial counselors and case managers, we're acting proactively as opposed to reactively. There are probably resources in the community, from social workers to elder services to other services, that we can be more proactively engaging. So one of the things that we've done to just start the process is we've partnered with a healthcare transparency company called Amino to start to educate clinicians in how to engage patients around not just appropriateness but affordability. And so every physician with an NPI number now that completes that training will be identified on the Amino website. And this won't be easy. This is a first step. The second and third steps are likely to be harder, but the last 5 years have demonstrated to me that medical educators are capable of driving necessary transformation even against the odds. So thanks very much.
Good morning. So as Alan mentioned, we're looking at where we're headed in the Choosing Wisely campaign. But to really understand that, it's important to understand where we are now. We know that the Choosing Wisely campaign is designed to promote these conversations between providers and patients. And as providers are the ones having to actually execute the orders and really carry out a lot of the burden of this campaign, it's important to understand how aware they are of the campaign as well as their impressions of both Choosing Wisely and low-value care in general. So for this study, we compared results from a 2014 and 2017 survey conducted by the ABIM Foundation of physician perceptions of the Choosing Wisely campaign and low-value care. Just a brief overview of the methods. Like I said, this was a 2014 and 2017 survey. In 2017, this year was conducted between March 9th and April 5th, was a telephone survey drawn from a probability sample of around 15,000 records from the AMA Physician Master File. We had about 600 respondents in each wave of the survey. As you can see, general practitioners were oversampled deliberately, as it's generally a bit easier and more cost-effective to reach them than specialists. Our data was weighted by region, gender, age, and type of practice. Now, the response rate for the 2017 survey is on the low side at only 5.3%. We did want to point that out. Generally, physician response rates across the board on all surveys have gone down pretty dramatically over the years. And it was a result of balancing, achieving a low margin of error as well as costs of administration. In our online appendix for our paper, we conducted a full non-response analysis comparing survey respondents to non-respondents, as well as a comparison to the national physician population. So those results are all online, and you can see any significant differences in subpopulations there, but we didn't see anything jarring that would make us question our results. The next 3 slides I have are just presenting some of those large overview survey results in a graphical form. We were very fortunate that this survey was administered exactly the same in 2014 and 2017, meaning the content of the questions had not changed. So you'll see the exact same questions compared between 2014 respondents and 2017 respondents for each particular question. Now, this first slide focuses on physician awareness of the Choosing Wisely campaign and their views of it if aware. So let me just take you through this. The top half of the graph shows just among all respondents awareness of the Choosing Wisely campaign. Unprompted, meaning just asked if they were aware of the Choosing Wisely campaign, and prompted, they were given a particular explanation of the campaign. We saw slight increases in both of these populations, prompted and unprompted, from 2014 to 2017. However, we did not find that these differences were significant, so awareness largely remained constant between the 2 years, same as among those physicians who had actually viewed Choosing Wisely campaign materials. However, on the bottom half of this graph, we look at among physicians who are aware of Choosing Wisely, how they view the Choosing Wisely campaign materials. As you can see, the overwhelming majority of physician respondents found campaign materials to be helpful to both physicians and patients. And in terms of viewing the value of the campaign, over 90% in both years of physicians who were aware of the campaign viewed it as valuable. Next, this exhibit's looking at the percentage of physicians who were comfortable having conversations about value with their patients. You'll see at the top part, it asks about a change in difficulty in recent years. The way the question's framed is asking clinicians if it's become easier or harder to have these conversations around value with their patients. As you can see from 2014 to 2017, the percentage that found it to be easier actually decreased, and the percentage that found it more difficult increased, but these changes were not statistically significant. The bottom half of this exhibit asks physicians about their overall comfort level in having conversations around value. Very comfortable, somewhat comfortable, or variations on uncomfortable. Here we actually saw a significant decrease in physicians who were very comfortable having discussions about value with their patients. We saw a corresponding increase in somewhat comfortable, but that was not significant. But overall, you can still see that the majority of clinicians are comfortable having these conversations around value with their patients. Finally, this exhibit asked for clinicians to identify the reasons for the drivers of low-value care, why they thought it was happening. It's important to note that these categories are not mutually exclusive. Respondents had the option to select more than one option, and on average, respondents selected 5 different drivers of low-value care. We saw significant increases in the majority of these from 2014 to 2017, with the highest being malpractice concerns, has been previously addressed. Other high contributors identified by respondents were dealing with uncertainty as well as patient demand. Kind of big picture, what to take away from this from a policy perspective. As Arthur identified earlier, those 2 major drivers identified by clinicians being malpractice liability and patient demand. Physician responses in this survey don't really square with what we've found so far in the research literature in terms of actually quantifying how these behaviors are driving low-value care. So in terms of future research, it's important to try to disentangle physician perceptions of the drivers of low-value care versus what's actually showing up in the empirical research data, because there's a definite disconnect there that would benefit from future research. Thank you.
Thank you again to RWJ Health Affairs, ABIM, for inviting me here today. So I'm going to talk about my recent paper, Low-Cost, High-Volume Health Services Contribute the Most to Unnecessary Health Spending. So I'm going to just talk about low-value care from a real patient's perspective and an example of the iatrogenic cascade. Jim is a 59-year-old man with a history of mild intermittent asthma and a painful abdominal hernia who's at preoperative clinic to be evaluated for surgery. At the visit, an unnecessary preoperative chest x-ray was ordered showing a lung nodule. Surgery is then delayed and a CT scan is then ordered. The CT reveals an incidental adrenal mass. The surgery is further delayed, and then an adrenal CT is ordered, and that adrenal gland CT finally shows a benign mass. All this time, Jim lived in pain for an additional 6 months. He was anxious about the test results, and he received an unnecessary dye load that could have harmed his kidneys, unnecessary radiation exposure increasing his risk for cancer, and the scans cost more than double the surgery itself. This was a real case published in the Teachable Moments series that Neel just helped to found. The best way we can make headroom for innovation in healthcare is eliminating low-value care. This quote is attributed to Michael Chernew, who you'll hear from in just a couple moments. Low-value care or patient care that provides no net benefit in specific clinical scenarios can harm patients, just as we saw in our case with Jim. Despite knowing about this problem for decades, low-value care persists. Policy focus has really been on reducing high-cost, low-value services, but few have assessed the range of costs of low-value care. So in this context, we used the Virginia All-Payer Claims Database to assess 44 measures of low-value care in 2014. Now, important caveat before I move on is that these 45 measures don't represent all low-value care. They're just a small slice of it, and these claims measures were chosen based on their ease of measurement. So we use the Milliman MedInsight Waste Calculator, which applies choosing wisely recommendations and other evidence-based clinical guidelines to administrative claims data. And costs were essentially the average amount of money per service paid to a healthcare provider averaged across all payers, and this included patients' out-of-pocket spending. Among 5.5 million beneficiaries, 1 in 5 Virginians received at least one low-value service in 2014, and this matches with national data. The 44 low-value services were delivered 1.7 million times, which cost the state $586 million, or 2% of healthcare costs in Virginia. Here's a table of the 3 most costly low-value services in Virginia. Now, the first one, baseline lab tests for low-risk patients having low-risk surgery, only costs $487 per service. This is a very relatively low-cost item, but it actually contributed to half of the spending, $227 million, because it was high in volume. It was delivered 467,000 times, and 79% of the time it was inappropriate. 21% of the time it was appropriate. In contrast, we have stress cardiac testing in asymptomatic low-risk patients, a more costly procedure at $3,500, and a lower volume procedure at $27,000, costing $93 million. And annual EKGs is the third example, another very low-cost item, $298, again with its high volume making up for it and costing $41 million total. Here's a pictorial representation of the volume of low-value services, the number of times low-value services were delivered. So the total was 1.7 million times for all the low-value services, and the blue colors signify the low-cost services. So less than $538, or the median amount of spending. And 93% of the low-value services that were delivered were these low-cost or very low-cost items. So they comprise the bulk of care in terms of low-value care that we measured. Now, when you look at the cost distribution, what was striking to us was that 65% of the spending came from the low-cost or the very low-cost items, double the amount of spending as we saw compared with the high-cost items. So the surprising lesson for us is to don't discount the small potato items because they tend to add up. So among these measures, low-cost, high-volume care contributes the most to unnecessary spending. Again, this is not all low-value care, but among the measures we studied. This has important implications for reducing spending without harming patients or reducing quality or access to care. Now, again, most of the focus has been on high-cost care, but these findings give us leverage to perhaps begin a pragmatic path forward. Low-cost items are less likely to threaten a particular clinical specialty or advocacy group. They're more widespread, and they tend to be, again, low cost. Now, as a backdrop in terms of the policy world, it's actually a little-known fact that the Affordable Care Act has a clause that states that payers should provide no payment for health services that have a grade D recommendation from the U.S. Preventative Services Task Force, such as population-based screening for vitamin D deficiency. These are examples that were written into policy thanks to Mark Fendrick, the study's senior author, and many others. So there is some policy backing of this, but so far, this policy has not really been executed widespread. So partly as a result of the momentum generated from our paper, and thanks to hard work from Michael Chernew and Mark Fendrick, and Michael Chernew started a multi-stakeholder task force to identify 5 commonly overused services that are ready for action, ready to be eliminated. Diagnostic testing and imaging prior to surgery, vitamin D screening, PSA testing in men greater than 75, imaging in the first 6 weeks of low back pain, and branded drugs when identical generics are available. So this task force consists of employers, health insurance plans, patient advocates, researchers, and other policy experts. And the group really challenges policymakers and payers to begin the action of engaging physicians to reduce these 5 low-value services to gain some momentum for the broader movement to tackle low-value care. Thanks so much.
Morning. Well, I want to thank the Robert Wood Johnson Foundation and the ABIM Foundation for inviting me to speak here today. I've had the great privilege of working with the ABIM Foundation and Daniel Wolfson for the past several years on choosing wisely topics. And I've been particularly impressed by the uptake, the growth of Choosing Wisely, the campaign in just 5 years. And I just want to reiterate, just 5 years, that we're here when this campaign started just 5 years ago. And this graph shows the growth in recommendations, the growth in societies that have contributed to recommendations. And the growth, the articles I show on this slide is just the articles that have interventional components to reduce low-value care. And that's really remarkable because, look back to 2012, there were hardly any. Overuse isn't a new problem, but Choosing Wisely helped accelerate our understanding that we need to do something about it. And so that these interventional articles are still coming out, and that's growing, that's expanding, is really, I think, a testament to what Choosing Wisely has been able to start in just 5 years in a way that guidelines, which have been going on since, the 80s, they haven't been able to do, which performance measurement can't do. But Choosing Wisely, I think, has really started to allow us as professionals, and I want to stress that the Choosing Wisely campaign has really tapped into that fundamental element of professionalism and allowed us to say that this is really important. But you've also heard that we have some work to do, and that while Choosing Wisely has had tremendous growth, there's still a gap in physicians recognizing Choosing Wisely, in the change in practice. And that's really not surprising, right? Because it's been just 5 years. And you've also heard that practice change is really, really hard. And so where are we going to go in the next 5 years in order to accelerate the progress that's already been made? And actually, I'm going to talk about these 4 recommendations, but I want to stress that actually the speakers today have already given examples of what to do right. They've already given examples of these 4 recommendations. And so these recommendations, even though it wasn't planned ahead of time, actually kind of codifies what a lot of these groups are doing right to help other organizations do so as well. So the first of our recommendations, and also I want to thank my colleagues Jeff Colgren and Samir Saini. We have a paper coming out in Health Affairs today, and we did this work together. So the first recommendation is to use strong methods in developing the Choosing Wisely recommendations in the future. Now, currently, societies use varying methods, and you heard from Richard Barron there were fundamental principles which societies needed to follow in developing Choosing Wisely recommendations, but the process in which they could do that, although it had to be transparent, it wasn't standardized. And that resulted in recommendations that did not always, although many, if not most of them did, they didn't always focus on services that had high prevalence or high impact. And they also didn't coordinate recommendations in any way. So this was a great start. We have a lot of recommendations, a lot of societies joining the campaign, but what can we do in the future to make these recommendations stronger? Well, we propose that societies work with Choosing Wisely to now standardize the processes, and some societies have already done this. They've used Delphi panels, they've used surveys of their membership, they've used very clear syntheses of the evidence, but we propose that actually that be standardized and that societies have a path to follow in developing recommendations. We also propose that societies work together to consolidate some recommendations. So for example, imagine if internal medicine, family medicine, orthopedic surgery, neurosurgery, physical therapy, nursing, and pharmacy all work together to put together recommendations on low back pain. And low back pain was one of the things that John just mentioned. We have lots of recommendations in Choosing Wisely on low back pain. Why don't we come together, make unified recommendations about what not to do, perhaps also what to do? And I think that would be very powerful for our patients, for our profession, and also for dissemination. So our next recommendation is about innovative intervention methods. And what You've heard today, actually, Matt Handley mentioned this, is it's so important to understand the context in which overuse is happening. But if you look at the published literature, and Kerry did this, and she looked at the methods that interventions are using, those interventions don't always assess the drivers of overuse. And they also don't focus on kind of broader cultural change, so they look at one recommendation at a time. But they don't look at interventions kind of more broadly. And so we recommend that in the future, organizations undertaking interventions really look at the target root causes of low-value services. They leverage existing behavioral science techniques so that they could better match the root causes with what might actually work. And they also pursue cultural change among clinicians and patients. And what can we do to make that change now? Well, funders actually can encourage the use of relevant behavioral science techniques. And editors can also do that when they're reviewing a paper and say, well, what did this intervention look like? Did it actually target the right things? And it's also very important to still continue innovative public campaigns to raise awareness and attitudes for both clinicians and patients. Our next recommendation focuses on meaningful evaluation techniques, and we believe that evaluations to decrease low-value care should include more meaningful and rigorous approaches. Now, we have great examples of meaningful interventions, but a lot of our interventions, and again, if you look delved up into the literature, you have kind of pre-post, before-after designs, but not really any in-depth analysis of how well the intervention worked. And I believe that we can use pragmatic yet still rigorous designs that include patient-reported outcomes, include looking at unintended consequences, that can give us a much more robust view of how the intervention worked, and that will allow those interventions to translate much more easily to other settings. Finally, we recommend a focus on collaborative dissemination, and I think that the speakers from Washington State and Maine did a great job exemplifying what can be done when a whole state comes together. If we bring together states, communities, patients, payers, health systems, and academic partners to test and disseminate successful approaches, we can really make progress across the whole country, and we need to figure out how to make those kinds of effective collaboratives really go beyond just a few states. So, as you've heard in the past 5 years, the Choosing Wisely campaign has created a foundational pathway by which patients and providers can begin to discuss when to avoid unnecessary services, and a lot of progress has already been made. As we've described, several important steps remain to fulfill the promise of Choosing Wisely in the next 5 years. And it is now time, I believe, for all of us to start taking those steps in order to make sure the progress continues. Thank you.
I want to kick off with a couple of questions, not individually to each of you, but ask those of you who want to say something about them to weigh in. The first, and it started, Neel, in your remarks about the role of medical education and integrating value into the discussion. Choosing Wisely is an initiative situated in a broader context of change in healthcare, particularly the drive toward measuring value, paying for value, rewarding value. And what I'd like each of you to reflect on, if you care to, is the degree to which we should be having a conversation about this campaign, the degree to which this is just part of a broader movement, the degree to which those line up and are self-reinforcing, or if there's some conflict between them. it seems to me thinking about the future of choosing wisely requires thinking about the future of the context, and the context is one where we're having a lot of conversations about value that we didn't used to have. So I wonder who'd like to weigh in on that.
I think a first cut at it. I was thinking, actually, as I was hearing the beginning of this meeting, that there often when you talk to professional groups in healthcare, a lot of the solution involves closing an ignorance gap and solving it through education. That if we only knew what to do differently, if we only knew better. And then when you talk to policymakers, it's about fixing incentives. And my experience has been that by and large, we have a lot of very well-informed, very well-intended people who mess up anyway. And that requires blaming the system itself. And thinking about some of the progress we've made in the context of some of the tactics that I think were brought up, like how do you make the right thing the easy thing? I think I heard that. That made a lot of sense to me. But I think one of the things that at least I was hearing is that no one of these things is sufficient by itself.
Other thoughts on this? John?
Is this, it's on there. So I totally agree with Neel. In the relatively short time that I've been studying this field, I'm increasingly convinced that there really is no one-size-fits-all solution. There's no one single magic bullet that's going to fix this. That many of these levers, such as financial incentives, are important but insufficient by themselves. Culture change, again, is going to be, you're going to be pulling teeth if it's a pure fee-for-service system, as we were just talking about earlier. And all these things together are going to be really critical. Education is a critical part. If you look at doctors are really slow to change. In the 19th century, hand washing and surgical scrubbing techniques were slow to adapt, and so some of the leading proponents gave up on doctors and they just focused on medical students because they were more open-minded, and it finally kicked in and finally worked. So education is a really critical piece of this, but if we're going to make a dent, it's going to be a multifaceted approach with multiple stakeholders doing all kinds of different methods together iteratively, and we're probably not going to be able to know why it got better if it does, but hopefully it will, and hopefully it will be minimally causing unintended consequences, such as cutting down on high-value care, and that's a really key thing to watch for, as Eve mentioned just earlier. So, just some thoughts there.
Great.
Yeah, so I agree with everything that's just been said. I think the other thing we need to just keep a focus on is this issue of professionalism, right? And at Michigan, our CEO has basically said, I understand that this may, if we do choosing wisely and if we decrease unnecessary care, it may mean a decrease in income for some areas for some short period of time, but it's the right thing to do. And I think if we have to focus on that is the cultural piece. Everything that's been said, the multifaceted interventions, the multiple approaches, but we have to start with that belief. And so I think that tapping into that professionalism and all of us leading the way is going to be really important continuing into the future.
And in terms of one of the other interesting findings that we found from the survey that I didn't present, physicians were also asked to identify reforms that they thought would help them reduce the presence of low-value care. And tied for the #1 response that we heard at 92% was they want evidence-based recommendations formatted for discussion with patients, which is, of course, one of the tools provided by the Choosing Wisely campaign. So even though we're seeing that lower awareness of the Choosing Wisely campaign and it remaining a bit constant, physicians still want those tools. So in terms of Alan's question relating to choosing wisely versus the broader conversation around value, I agree with my co-panelists that choosing wisely is one tool to get there, but it's really more about getting providers and clinicians and patients to engage in those conversations about value, whether it be through this campaign or in a broader context.
Those last two responses actually feed into the other question I had for all of you. And It goes back actually to, I think, the first or second sentence of Rich Barron's comments about the mission of ABIM to strengthen professionalism. And you all are speaking about the professionalism side of this, the training, the professional norms, all the things that one associates with professionalism. But there is this other side to the conversation, which is the patient. And in our earlier panel, we heard a lot about changing culture, not just within the institution where clinical practice occurs, but the broader culture in which all of this takes place. I just wonder how far we can actually go with this as a professionalism initiative, and how much it needs to be thought of as a broader cultural movement, and the role, the history of professions changing the world is actually not great because they tend to resist change. So is there a wall we're going to hit? I'm just curious about how we make this more than a professional movement.
My experience has been that actually clinicians take their sense of professionalism so seriously that the worst thing that you can call a clinician is unprofessional. I can think of a lot of bad things to call somebody, but unprofessional is actually the worst thing that you can say to a clinician. So I think that there's real power in that. That being said, I think that there's clearly room for this to be more than a professional or professionalism issue. And I think one of the first steps to creating an organization or initiative, a campaign of any kind, is to have basic goal clarity about what we're trying to do that's steeped in the underlying values. So not thoroughness, but appropriateness. And hopefully in the next phase, not appropriateness alone, but appropriateness plus affordability.
Yeah, so I think that engaging patients is going to be key. I think that when we start talking about appropriateness, we also have to remember that there's two sides to appropriateness, right? So there's, and this was mentioned already, that we make sure patients get the care they need and not care they don't need or may harm them. And as long as patients understand that that is the goal and that they are active participants in that discussion, I think that we need to continue to push that. The other parts that we haven't touched at all about in terms of policy reform are things like medical malpractice reform, which in, I think, your survey and in our survey also is very high on the list. And so there are going to be these other elements that if we're really going to make inroads over time, we're going to have to tackle. But you know, for now, the public campaign, I think, is going to be increasingly important. And Consumer Reports has been great on that, but we also have to think in our own communities, like the Maine presentation, how we can get that word to our patients.
Yeah, changing culture is really, really hard. And just to reiterate what I said earlier, I think getting young trainees to grow up in this culture, to start their careers about value, is one of the sort of ground up ways in which we can actually move beyond the profession. And I agree with Eve, engaging patients is critical, but where the rubber meets the road, it's really challenging. As somebody mentioned earlier, doctors on average have about 15 minutes per visit. It's often just easier to order the antibiotic or order the MRI as opposed to spending 5-8 minutes on a shared decision-making conversation. And so in a system where the finances are aligned and you provide physicians and patients with the appropriate tools such as decision aids, perhaps you can make a difference. As Cochrane meta-analysis showed, that when you do engage patients in shared decision making, they do actually, they are less likely to undergo unnecessary tests and services. But it's really challenging. And what I've learned in the literature is, at least on the professionalism side of engaging physicians, which is still an important piece, is when you focus on the cost to society, it's hard to get them motivated. But study after study, including a randomized trial recently published in the Annals of Internal Medicine, has shown that when you focus on the harms of overuse, then physicians start to pay attention. Now, you want to be careful not to overstate the harms, but if you show them the appropriate data data, then you get frontline providers more likely to be engaged. And moving beyond the profession, I think you're probably going to get patients to be more likely to understand as well. That's how I focus on it in my day-to-day practice, at least.
Great. Let me open it up to those of you in the audience. I see someone in the very back and someone else in the very back next. We'll move forward.
Hi, I'm Andrea Broussard from the Center to Champion Nursing in America at AARP, and we're on a Robert Wood Johnson funded grant also, implementing the recommendations of the future of nursing and how. And now we're moving more onto the other big Robert Wood Johnson push, the culture of health. So I was listening and seeing if there's going to be a discussion on how we can intersect the Choosing Wisely campaign with the culture of health, you know, including patient engagement and provider work.
So I don't know if that's something the panel is best suited to respond to. I mean, I think from Susan's comments at the opening describing how they interrelate, but I think then in terms of action steps that give that meaning other than the evolution of the campaign itself, I'm not sure. So I think I'm going to not ask these folks to respond because it's a little bit more foundation oriented, but I think we had a nice introduction to the topic earlier this morning. Glad you brought it up. There was someone, oh, you moved over.
Yeah,
Thank you.
I did. I came to the mic this time. Hi,
Thank
good morning, everybody. I am Dr. Joya Career-Perry. I'm a lot of things like Neel. I'm an OBGYN, but I'm also today representing being on the board of the National Medical Association. And Daniel came to one of our meetings talking about this low volume and choosing, and it really didn't resonate, honestly, a lot for physicians of color and people who work in low resource institutions because a lot of our patients' choice is way down the list. And what you talked about earlier around the things that physicians are worried about as far as malpractice and patient demand, that's really about bias. So when you're thinking about the future and aligning kind of what our biases are as providers versus what the realities are when you're working in low volume places, like was mentioned, the test around EKG, a lot of those things and across payers are happening. Are you thinking about how you could work on changing the language around bias and what physicians think versus what the truth is?
Great question. Who?
That's a really, really good question, a really tough one. There is widespread bias against gender, race, ethnicity in healthcare. There are wide disparities in patients not getting necessary care, patients of color in particular. And it's a horrible problem that we're facing in our country we're all trying to solve. And it's challenging when you have a population that you're taking care of to say, look, we want to actually provide less care. It's very awkward and difficult. And I've had the privilege to collaborate with Eric Weil at the DHS county system, and learning from how they're engaging patients has been very, very important. So in the instance of preoperative testing for cataract surgery, what I learned in watching what they have been doing, patients tend to actually really like not having to come in for their tests. They don't have to miss work, they don't have to pay for parking, and even patients who weren't getting cataract surgery were like, well, how come I have to come in to get tests? But you have to be very careful, and you have to be thoughtful, and you have to watch for unintended consequences. We were not expecting to have a 6-month improvement in wait times, but that improvement was really a big benefit for patients. They had 6 months of improved vision because we got rid of all these unnecessary tests. So that was a nice benefit. But you're absolutely right. You have to have that in mind. I think it's always important, the 6 domains of quality from the Institute of Medicine, you have to keep all those in mind. So what is care efficient? Is it effective? Is it safe? Is it patient-centered? Is it timely? And is it equitable? You have to really have all 6 of these in mind and watch for unintended consequences.
I just have to add, when it comes to bias, it's not just views of the other. I am struck by the results of 75 to 80% of physicians saying they're very comfortable discussing low-value care with patients. I wonder how that really plays out. I'll just say we've published on, we had a terrific qualitative piece last year on, with someone recording clinician-patient interactions and all the missed opportunities to talk about costs. So I don't just say that without some evidence behind me. It's an area of concern. I see someone here in the back and then in the middle, and then we're probably going to be running on time, but let's see what we can do.
Hi, Casey Quinlan. I'm also many things. Not a doctor. I am a writer and a patient loudmouth troublemaker, but in partnership with clinicians. One of the things that's kind of like the elephant in the room always with the cost discussions is the lack of transparency available to people, patients, and doctors making decisions in a clinical setting about what the cost of various choices would be in that shared decision making. Is there any hope for us teaming up to fight that dragon, or are we just stuck on this loop? What do you guys think?
I'll jump on this one very quickly. I mean, I think that there's hope. I was early on the bandwagon to put prices on the menu. I think it was Abraham Verghese who said if you're ordering off a menu with no prices on it, it's easy to get the filet mignon every time. That being said, there are 3 failures at the point of care, and lack of insight into how our decisions impact what people pay out of pocket is only one of them. So we don't know what things cost. The second is that we often order things that are not appropriate. And then the third is sometimes things are expensive and worth it. And then we don't know how to surface the many options that often exist to help people afford it. And so I think even in the absence of price transparency, that's not an excuse for not moving forward and trying to find solutions that can get people to appropriateness and affordability.
Someone in the, yep.
So I'm struggling with how to word this, but
can you just tell us who you are?
Oh, I'm Hillary Brandt. I'm a DNP candidate at George Mason University.
Thanks.
I was struck by the medical education and then the bias. One of the things that I've experienced in my my clinical rotations is I've been in a facility that has a lot of access to excess. Order whatever you need. And then one of the things that we're required to do is to work at one of the Mason and Partners Clinic, which is a free clinic, bridge care for indigent care. So I'm wondering if anybody has any thoughts of how to integrate something like that into medical education so that you do have education on how to provide care to people when you don't have access to anything.
So this seems like a critical culture question, particularly culture of education. There's been a lot of discussion about moving people out of hospitals in training and getting exposure to different kinds of populations. It seems like different settings might also expose people to different cultures around patterns of use. I don't know if any of you want to comment more on that, or?
Yeah, it's a great question. I'm certainly not an expert on that particular topic, but I do know that in looking at national studies, particularly recent ones by Michael Barnett and others, overuse is everywhere. We see overuse in patient populations that have Medicaid, safety net clinics. We see overuse as well in fee-for-service systems, and we see overuse across the world in single-payer systems. We see overuse in free clinics as well. So it's sort of rampant and everywhere, and so it just underscores how complex the problem is, and it's not just about finances. But in particular I do work at a free clinic every Monday afternoon, and it is challenging to get patients to access specialty services, and there's a lot of unneeded care that doesn't happen. But I think that just underscores why there isn't a one-size-fits-all solution, that a solution in a large academic medical center that's fee-for-service is not necessarily going to be effective in a FQHC, or federally qualified health center, and that physician engagement, culture change, education, giving patients and physicians tools and time and resources is really going to be critical. But it's that kind of work has to be, I think, oftentimes from the ground up.
Here.
Hi,
I'm Dr. Phil Polikoff. I'm a consulting professor at Stanford University School of Medicine. I'd just like to share with you a disruptive reflection to think about. In these times when I is replaced with we, even illness becomes wellness. We can only work towards a healthier America together.
I think we'll let that stand for adding would only detract. So let's see here, and I saw someone in the back. The back is speaking up in this session.
David Atkins from VA Research, a great panel. So I think choosing wisely has really helped change the culture and the discussion. But I think from our perspective in a integrative health system, which does have a slightly different culture, we still see tremendous variation at the provider level. And I think, I'm sure my Kaiser colleagues probably bear that out. I mean, we have twofold variation or more in ordering probably low-value care. And I'm wondering how far we've gotten in terms of understanding the behavioral issues around those providers who are using a lot of low-value care and how to actually change their behavior.
I'll take that. So thanks for that question, David. And in fact, it is true, and to follow up on John's point, that we do see overuse everywhere. We see overuse in the VA, which is, as you know, a capitated system. But we see less overuse in the VA than we actually see in the private sector, and we've done some work on that. There is tremendous variation at the facility level. And we haven't necessarily drilled down to the individual provider level, but I think if we did, we'd see that as well, and I know others have. But this is why it's so important to understand the drivers, because if you've seen one organization, one facility, one medical center, even in an integrated medical system, you've seen one medical center. And the cultures are different in each medical center. The ability to refer to specialists, the ease of getting CT testing, for example, you know, if you have your own imaging, if you have to send patients out and so forth, how far people have to travel, all those factors vary. So this is why it's so important, even when you're taking a intervention that seems like it worked somewhere else, to actually modify it, to understand in your own facility, in your own organization, what are the drivers of overuse in that setting? Because you may have to adapt it. And if you're doing interventions, any of us who are doing interventions should really be studying them in enough depth to be able to tell, if I'm doing one, that I could tell Beth at Kaiser that, hey, these were the drivers in our organization, these were the barriers, these were the facilitators. So if you're going to take it and now transport it to Kaiser, you need to look at that first. So I don't think there is any one answer at this point, that we know that it's, you know, younger providers or older providers or ones without, you know, certain degrees or certain patient populations. I think it's going to be a compendium of factors, and a lot of it is going to be local.
Just to jump off of that comment, while I entirely agree that there is a need for local adaptation, and that, you know, you start off by looking at just illuminating the variation, trying to figure out what the positive and negative deviants are doing differently, there is a tremendous opportunity throughout healthcare to just define what are the things that ought to be reliably happening for every patient every time in every domain. Like in childbirth, the most commonly utilized healthcare service, which is 0.6% of our entire $17 trillion GDP, just hospitalizing people in childbirth, 11,000 times per day in the United States. Hundreds of thousands of labor assessments per day in the United States. We don't know what are the things that ought to happen during a labor assessment for every patient every time. That is undefined in the United States and everywhere in the world. That's crazy. And that, you know, there's a real opportunity there. I mean, it's not impossible to do.
Just one last point. Again, I agree 100% with what's been said, and particularly, again, there is no one-size solution, but there are a number of tools to test locally and see if they work, following the data, watching for unintended consequences. Somebody mentioned earlier, I think Arthur Hong, behavioral economics as a tool. And for a small selection of black and white issues, like some of the things that we mentioned, such as using generics when using a brand name when a perfectly equal generic is available. The power of default is one idea to consider, where there's been study after study showing that if you just have a default, you can very easily influence with minimal disruption to workflow the use of brand name tools. There's another idea called accountable justification, which uses the idea of physician professionalism, and this is again born out of behavioral economics, where if you want to prescribe a low-value antibiotic, you have to publicly justify it in the medical record. And it is disruptive, but it does substantially reduce inappropriate antibiotic prescribing. These are one-off. They're not going to solve everything. They're iterative, and I guess this is all taken in the context of broader financial aligning and culture change and patient and physician engagement. But looking at different tools to try locally, I think, is going to be really important.
Take one last question, very back corner there, gentleman in the corner.
Thank you. I'll try and be quick. I'm Richard Seifman from the National Physicians Alliance. My question really is related to Dr. Kerr's comment about teamwork, and I was also relating it to the point about the time doctors have. What degree could physician assistants or other members of the team pick up the responsibilities that relate to choosing wisely, for example, with regard to antibiotics or other things? So I just wait for the answer. Thank you.
So, yeah, it's a great question. And it's already been said that, in the 15-minute visits that we have with our patients, it's really hard to do the shared decision-making we need to do. We have done interventions where the people who are just checking the patient in, they know, oh, you're here for low back pain, or you're here for what sounds like a URI. Here's a handout from Consumer Reports about what you might need and might not need for low back pain, for example. And so that the patient is already, potentially primed about that, or they give it to the doctor, so the doctor can actually just hand that to the patient as they're having a discussion. It shortens the time. So that's certainly one way to do it, but getting our staff, whether it's our pharmacist or our PAs or nurse practitioners or nurses, LPNs, much more involved in a team-based way, I think is really going to be very instrumental. And you have to get everybody on the same page. So if we're doing an intervention now where we're focused on trying to decrease over-treatment of diabetes in older patients, and if we don't have the pharmacists really engaged with us and they're doing a lot of the medication management, that intervention is going to fail. And so having that teamwork, I think, is going to really be essential for especially very clinically based interventions.
Let's comment. So I think somebody once said, very wise, that one of the most underutilized resources in healthcare is the patient. And so I think that there are some ways to creatively think about engaging patients in decision making. I've been fortunate to work with the Open Notes team and getting patients to have access to their physician's notes, getting them engaged. It at least seems to improve their experience with care. But the phase 2 of it that we're going to be writing about soon is called Our Notes, which is the idea of getting patients actually actively to contribute to the note before the visit, outside the visit, where they talk about their agenda, perhaps even review a decision aid about low back pain or prostate cancer screening before the visit, and so that the visit is really primed to have a much more informed and efficient discussion about shared decision making. Now, that's a great idea, but operationalizing something like that is another story. So we're going to have to wait and see. There's a number of pilots happening. This is, I think, partially funded by RWJ and Jay Peterson and others. We're going to see what happens at Beth Israel Deaconess, at University of Washington Medical Center, Geisinger Health, but stay tuned for that.
Great. We're going to turn to some closing reflections, but please join me in thanking this panel. So it often falls to me to try to summarize the lessons from the day, but you get better than that for sure. We're going to hear from Daniel Wolfson, Executive Vice President and Chief Operating Officer of the ABIM Foundation, founding President and CEO of the Alliance of Community Health Plans for 2 decades before he came to the ABIM Foundation. Mike Chernew, whose name has already come up in conversation, the Leonard D. Schaefer Professor of Healthcare Policy and Director of the Healthcare Markets and Regulation Lab in the Department of Healthcare Policy at the Harvard Medical School, and the announcements that you were teased with. So I'm going to hand it over first to Daniel.
Thank you very much, and I just wanted to say thank you to Alan and Health Affairs and Robert Wood Johnson Foundation and all the specialty societies, all the partners, Consumer Reports, and so on. But I have 2 announcements today, and I think this is indicative of the Choosing Wisely campaign. We're about partnership, collaboration, and leadership. And so we have 2 announcements today, and I think this is a part of the spread strategy that we have for Choosing Wisely, is partnering with others who can really put Choosing Wisely into practice. And we can't do that by ourselves for sure. And so we wanted to announce 2 collaborations today, one with the American Hospital Association. Jay Platt could not be here today. He's the Chief Medical Officer, but I want to share some exciting collaboration that we're working on with him and the team at AHA, the American Hospital Association, in partnership with the ABIM Foundation, the Cost of Care, Neel Shah's organization. We'll launch the High Value Learning Collaborative. We hope to be in at least 15 health systems beginning in 2018. So I think this is indicative. In fact, today we're going to talk to another hospital chain system, thinking about how to leverage the current resources of Choosing Wisely. And now I want to introduce Ann Greiner, who is the CEO previously with ABIM and ABIM Foundation, NCQA, NQF, a longtime partner. And we wanted to announce something. She is from the Patient Center Primary Care Collaborative.
Thanks so much, Daniel. It's exciting to hear about your collaboration with the American Hospital Association and bringing that to systems. And the collaboration with the Patient Centered Primary Care Collaborative is to bring Choosing Wisely into the ambulatory setting. And we are involved in a 4-year grant through CMS, CMMI, Transforming Care Practice Initiative. It involves about 140,000 clinicians, and so in year 3 and 4 of the grant, we're going to be bringing Choosing Wisely in. Our focus is around patient and family engagement, and so we've spent the last 2 years really helping clinicians in those practices learn about patient and family engagement and shared decision making, and we have focused on some clinical areas. So this will be broadening our focus. And we have 3 areas that we're going to really set our sights on. Reducing unnecessary opiates, low-value imaging, and antibiotic stewardship. So we're really excited about this and appreciate the effort to announce it here today.
No, I think Michael's going to. All right.
I guess it's. They're not sure if I should talk or not, which happens all the time. It happens all the time. It's difficult to do a wrap-up because you end up being put in a position where you're tempted to repeat what more knowledgeable and eloquent people said before you. And my goal is not to do that, so I want to give some broad reflections on where we are. And I'm an economist, so I have to start by saying that I really do believe that health matters. I think that people are motivated by providing better care. Dan and I have a blog that just came out with Health Affairs that talks about the importance of professionalism. I could go on at great length about the importance of value and a whole variety of things. But I say that in part because I want to lead into a sort of broader point, which is money focuses the mind. And I don't mean to imply that it's the most important thing or why they're doing choosing wisely. In fact, I would say the opposite is true. It is certainly not why they did choosing wisely. But did I mention that money focuses the mind? I'm not sure I did. And I would argue, and again, hopefully we'll have time to talk after, that the big health policy driver, the big force that's driving health policy in this country, no matter what we think about health, turns out to be money in a whole variety of ways. And so what's nice about choosing wisely is it actually brings together ways to save money and improve patient health. It has that possibility to be a win-win. And I should note, it's very easy to save money in healthcare if you don't give people healthcare. Just as a general, it took me many years of education to come up with that. And but the point is, we want to improve value. The whole point of this is improving value. So we want to figure out the healthcare that we deliver that's not very good. And we have known since the seminal work of Jack Wenberg and everybody at Dartmouth, in fact, you know, it should be a Harvard Atlas, there's a Dartmouth Atlas, and that there's been waste in the healthcare system. And, you know, every economist I know, every health services researcher I know has some geographic variations work that points out wasteful care in a variety of ways. The problem is that ends up being very, very broad. It's hard to go from broad measures of geographic variation in spending. So what should I do when I go to the office today? And what choosing wisely does is it helps make those sort of broad observations about waste concrete and actionable. And what we've seen, if you take all the presentations from today and sort of lump them together, I put them into sort of the following categories. First, the idea is just to identify what's wasteful. And I think choosing wisely by working with the specialty societies has identified a set of services that we think are wasteful. Collaborate in a variety of ways. We announced 2 collaborations right now, but across the spectrum of organizations to try and figure out what folks can do to think about that type of waste. One thing that's come out in a lot of the presentations, the role of measurement. It came out that getting the technical specs turned out to be really, really hard. John's work with the health waste calculator that Milliman has been involved in tries to go from the general notion of the choosing wisely recommendations to how to really measure it. And that leads to the next point about interventions, and I'll say 2 things about the interventions. The first one is there is not a one-size-fit-all intervention. As was pointed out, certain things are more important in some places than others, and how you do that collaboration with different folks ends up being stunningly important, and it all hinges on the ability to operationalize and measure these things. Choosing wisely makes waste concrete. And then the last point, and I think Eve emphasized this, and again, this is incredibly self-serving, but you know that, so I shouldn't have to declare it, is to evaluate how it worked. And I think it's that notion of both figuring out in a way that's collaborating with the medical community services that should not be delivered, which actually I thought was a huge, huge step, combined with measurement, intervention, and evaluation, that I think is a path that, broadly speaking, is useful. So I'll tell a quick, I have the misfortune, I know this is videotaped, I have the misfortune of chairing the benefits committee at Harvard University. And by that I mean great honor. And so we had a very generous insurance plan, 96% actuarial value, and that's just so you know, Platinum's 90, right? And we reduced the generosity of our plan to about 91, 92% actuarial value, and people got upset, and we had to have town hall meetings. So just as a general rule, if you ever do anything and you have to have town hall meetings, you've made a mistake. So we had town hall meetings, and the modal thing that people said was, there's not waste in the system. I just want to go do whatever my doctor says. I don't think there's waste, and how are you going to tell, you meaning me, tell us what we should or shouldn't do? The reason why we ended up working with Milliman to get the health waste calculator. The reason was not because we thought there was going to be huge amounts of waste that we could then just target and get out of the system, although that would be nice to do. The reason was we needed to be able to start with a discussion of waste that was more concrete than just saying, oh, there's waste, and do you know they spend more in Miami than in Minneapolis? That turns out to be true, but not as easily able to focus folks. And so essentially that's why we did it. And it's also why we started, John mentioned in one of his slides, the Waste Task Force, which was, again, with my colleague Mark Fendrick from Michigan, Go Blue. I told Daniel I'd say that. To identify specific targeted things you can do. Again, it's all about not talking about the vague concept about waste. It's identifying specific things. And John put up the slide about, preoperative testing, vitamin D, using branded drugs when there's a generic available. All of those types of things ended up being important. We often are criticized because it turns out to be a small percentage of savings. If you add everything up, all the stuff we've done, we get a few percent. So, I worry about that. My general sense has been, that's the tip of the iceberg. We know it's the tip of the iceberg. It turns out you can't get to the whole iceberg at once, right? So start with the tip of the iceberg. Then you can go to another tip of the iceberg. Just find the things that you can go after. For a whole bunch of things, small wins are important. If I knew there was a home run in healthcare policy, I would be sitting here just talking about the home run. I would just take my time and change the conversation and talk about the home run. I don't know where the home run is. So we have to accept that this is a journey. Sometimes I say the Choosing Wisely initiative. I think it's more of a movement. But anyway, we have to begin to find places where we can save money and improve the value of care. And if that turns out to be 1%, 0.5%, even frankly, if we improve care and break even, I'd be happy enough. It turns out that that's what I think that we need to do. And the ability to engage with the medical community to identify where those opportunities exist and then work with providers to save money is stunningly important. And I think that what you've seen today is people from a lot of different settings talking about their journey to try and provide higher value care. And so today is sort of one step, but we're at the very beginning of it, one step in that movement to do that. And it is hard. I would just, because Beth's here, I'll just say one thing. So Beth published the seminal work on McGlynn. Exactly. You're like Cher. Anyway, Beth published, I think it was 2003, I may have the date wrong, the seminal piece on the underuse of care. So we're talking about overuse of care today. There's a ton of underuse of really high value care that goes on. And even there, that ends up being a journey to get people to create value. It is not simply knowing that, 45% of the time people don't get the care, maybe it's 55%, but anyway, about half the time people don't get the right care that they should get. It doesn't automatically just materialize that now we're all getting the right things. And so we need to have organizations, and I think the clinical leads, places like the American Board of Internal Medicine Foundation, working with the specialty societies, is the way to move us forward. So anyway, I'm thrilled to be here. That was my ineloquent summary of where I thought the day was.
So I've always been told as a leader, you should let other people talk. So everything that's been said is fine. I should just go home right now. But they gave me a role, so I must do my role. So I wanted to maybe summarize what I heard. I thought that was our task a little bit. And then I also want to say what was unsaid, and maybe just things that I noticed that I thought were unsaid. So I think you heard from Richard Barron that there was a lot of talk about rationing and death panels in 2012. And I think we came up with a different frame and a different why to do this work. And I think that was really significant. And we listened in focus groups with McCabe messengers for a year or two before we framed this campaign. We spent a lot of time talking to physicians, and we think we got the messaging pretty good. Now, he used the word waste, and we keep refining our language. I can tell you physicians do not like to hear the word waste. So we've eliminated that from our vocabulary. But it's evolutionary, right? You learn and you refine. I also said one time at Cedars-Sinai, unnecessary care, and a physician raised their hand and said, care is never unnecessary. Care is always necessary. I was stunned. I didn't really get it for a while. But language is really important. We focused a lot on language because we wanted to engage. This was an engagement strategy. So I think the other thing that we really focused on with Consumer Reports was patients think that more is better. And we're trying to reverse that paradigm. More is sometimes not better. And physicians and patients are on the same page sometimes. More technology, more diagnostic tests, and so on. And physicians didn't think that this was their responsibility. it was somebody else's. It was somebody else's fault. It was the health plans. It was the government's responsibility. And we reversed that, I think, very strongly by engaging with the Specialty Society and saying, no, it's your responsibility. And so I think we did a good job of the ownership and responsibility of overuse on the physician. Now, they can't do it alone. They have to do it with teams. We've had clinicians, non-physician clinicians, nursing, OT, PT, chiropractic, and so on. But that was a big deal because if they don't own it, then you're just going to do workarounds on quality improvement. And if you think about the history of quality improvement, it's not involved the physicians very much. And that's a real huge mistake. Because there's a lot of physicians, there's a lot of clinicians, and you just don't want to have quality improvement experts going around and making changes. Better that the front line does it and is involved in the solutions. So we think we did that all right. I'm saying we did it all right. We still have a long way to go. This is just, as people said, this is just 5 years old. Massive change takes 15. So we're going to do it in 10. Low-value care was not taught in medical education and training, and Neel Shah, Chris Moriarty's changed that paradigm. Along with other people like ACP, it is being taught, and it's very creative. And in 5 years, I think we have a crop of physicians that are out thinking about low-value care. And in 5 more years, we're going to have a lot more physicians out there that have been sensitized to this low-value care. It has been a sea change. So we weren't thinking in 2012 a lot about system change. And sure enough, I mean, we have no magic potion about system change. And we're hoping to spark innovation. Eve Kerr has really been an innovator about de-intensification, not just using techniques that were used for underuse, but using different techniques and understanding that. But the magic potion that we have is that we attempted, and I think Matt Hanley did an excellent job of describing this, is that we've really thought about culture and culture eats strategy before we think about technical approaches. Culture can't do it by itself, but too many times we rush to technical solutions and we lose the clinicians. They didn't know why. So the other thing that hasn't been talked about, I just think that there are things to brag about as far as, system changes. Our grantees, thank you, Robert Wood Johnson and Susan Mende, have done an excellent job. We set out across 14 delivery sites to combat antibiotics, and 11 out of 14 had more than 20% reductions. Wow. And they did it in the peer review, peer-to-peer comparisons, clinical decision-making, order set changes, academic detailing, all the usual strategies. And on 30 of the 45 recommendations they were working on, they were decreased by 10% or more. But Eve's right. It's not standardized. We're still an experiment, and we're still experimenting with what works. And yes, we got to get to the stage of standardization, but I'd also say we got to be in the stage of experimentation about really what works, because we don't really know what works at this point. So maybe standardization might be premature. The one thing that wasn't said that I really want to emphasize is we're building communities. So communities of that are really about partnership and collaboration, as I was saying before. But let me just give you, this is all commercials for nonprofits, of course. Academy Health, we have a research community. Eve has been very active. Beth has been very active in this research community. You can join this community. Cost of Care has been an excellent collaboration and partnership. And 80 specialty societies. I want to know when 80 specialty societies have done one thing together. I cannot think of a time. Maybe there has been, but it's remarkable. We have a health systems learning group. Again, shining light on successes, best practices. That's what we can do, and we can begin to have a learning collaborative. Grantees, we have Kellie Rand is in the audience. We've had 20 past and present grantees who meet periodically and exchange. And we have a whole bunch of community and consumer partners. So it's kind of the landscape. And one thing that I thought Eve was going to talk about is that we're in 20 countries, and Eve's been involved in this. And so why? So I think what we can learn is about spread. And frankly, quality improvement has been terrible at spread. I mean, every conference you go to in quality improvement, they're talking about spread and how it's gone to one institution. But I think that the empowerment issues, the bottom-up approach, people having simple things to think about, 5 things, but being concrete, simple interventions, I think are really important. So I think some of those things that we've learned are applicable to quality improvement, but we don't have the magic sauce. It's got to happen at the local level. But I think people can point back to the specialty societies, giving a huge message that overuse is our responsibility.
Well, I will just close by saying at Health Affairs, it's great to be able to lift up those who are innovating, to celebrate the success, but also to look at the evidence, which is part of the celebration of success, and also the refinement and improvement and learning that needs to occur so that 5 years from now we're able to do this again with more progress, but also more, although I guess in 5 years we'll be done, according to Daniel. But in case Daniel's wrong, in 5 years it'll help set the course for the next 5. That continuous improvement is part of the ecosystem we like to be involved in. So with thanks to the Robert Wood Johnson Foundation, thanks to ABIM and the IBM Foundation, please join me also in thanking our closing presenters. And we hope you found this a valuable event. We'll see you next time.
No question.